So we will be sharing the learning from today with as many people as possible, and there will be recordings of the presentations with as much information as possible that can be given out into the public domain. So let's get going. Jen Shields, our first presenter. Jen is Principal Clinical Psychologist, Scottish Government funded. She is Fetal Alcohol Advisory and Support Team FAST and has been there from the very beginning, and is also an honorary clinical lecturer at the School of Health and Social Sciences at Edinburgh University. Today, Jen's presenting the work of FAST, the Fetal Alcohol Advisory Support Team. Jen.
I'm delighted to be able to speak to you on behalf of the Fetal Alcohol Advisory and Support Team. This is an update on behalf of Dr. Sarah Brown and I, and we're delighted to be able to be here today and to share our journey to date, and also to give an overview of our resources that we've created over the years. We're also really excited and delighted to share with you recent developments that have led to us bridging with the University of Edinburgh, and we also want to outline our future planned activity and aspirations in what we call phase 4 of the project of FAST, which is going to be within the University of Edinburgh, and that's going to allow me to talk about our work and our hopes in training, in consultation, and also in research. So just checking you can still see things all right. I can proceed.
Yep.
Excellent. Okay. So for folk that might not know us well, I'm sure quite a lot of people have seen us on our travels. The background, just very briefly, is that 10 years ago, Dr. Maggie Watts, who was Scottish Government advisor for FASD, was tasked with scoping out best practice examples in FASD from across the globe, and she selected the Canadian model and the associated international guidance from Canada as the best fit for Scotland. We in Ayrshire and Arran went on training, and I'm sure many other people in the room today might have been on that same training in 2012, and we began the phase 1 3-year pilot project, which was a local Ayrshire pilot project spanning CAMHS and community PEDS. We were tasked to collect and share knowledge and our learning about delivery of FASD assessment, diagnosis, and also intervention within the context of the NHS in Scotland. We gained some expertise and knowledge from doing the work, from over 200 assessments. And that actually spanned not just the paediatric service that we were based in, but also CAMHS in greater numbers, in fact. And also we were involved in some adult cases within the community mental health team. We subsequently devised resources and materials to support the work that we were doing in Ayrshire, and those were always for sharing from our website. And to date, and on the next slide, you'll be able to see the link that those resources are available. And this is just a list of the ones that we have. Understanding alcohol in pregnancy was really for everybody to use, particularly midwifery colleagues and primary care colleagues. We also had team members make an FASD summary leaflet. We also devised a Train the Trainer programme and FASD Awareness, and a parent and carer resource. These were some of the first ones that we did. And latterly, we've also got an educator's resource. You can see pictures of our resources there. And we've also been piloting post-diagnostic resource packs and diagnostic documentation packs for clinicians. And we also have published our service evaluation report, which you'll get the link to at the end of the presentation. Within that evaluation, we were very strongly encouraging thoughts about a third sector resource for FASD, and we're delighted to work in partnership with FASD Hub Scotland, who you'll hear from later in the day. This is the address that you can download those resources from, and that's a sort of a look at our service evaluation that contains a lot of helpful information about what we learned from the pilot project. We were very fortunate to be funded by Scottish Government colleagues, and to work with them and to see the commitments from government were really heartening in 2018. You can see here the alcohol strategy commitments, which is about improving support for individuals and caregivers, giving all our children the best start in life. And for FASD in particular, it was about raising awareness, improving early identification, assessment, diagnosis, and working together to set up third sector hub, standardising the education and training provision, and that's something that I'll speak about as we go on, because that's a huge piece of work. And we also we're glad to see the commitment to improving recording of alcohol histories during pregnancy, and we're really delighted today to be able to hear from Carolyn Wilson, who heads the team that we report to in regards to the bigger piece of work in regards to preconceptual framework and advice and support to people who are planning a pregnancy or who are pregnant. So this is a really good document to have a look at. In phase 2 of our journey, it's been quite a journey. 2018 to this year, we were, I suppose, asked to do more of a national remit, providing consultancy to all health boards to facilitate the implementation of the SIGN guideline that Patricia will be speaking about a bit later. That was published in January 2019. And part of our work was not only to raise awareness, which we did with many people, and I'm hoping there's a lot of folk, familiar faces if I could see you in the room today, who would have maybe attended some of those, and also the assessment and diagnostic training that the government ran over the years. And I think it was a couple of Junes ago that we were in the room with 120 people in Clydebank, and it was a really amazing training event. We have got our Train the Trainer package. We're going to speak a wee bit more about that later too. And more recently, we've collaborated on NESI learning resources, and Fiona Mckinley from Scottish Government is going to speak about that today as well. We were also committed to trying to advance research in the evidence base, and that's something that's in progress and that we'll speak about. But in order to really build sustainability in our team, we're a very small resource and mindful of that. We've had a lot of lovely people work with us along the way, but the core team has remained quite small, and we needed to have a vision for FASD for Scotland. And Sarah and I had long conversations and debates about where our team should be and where we should be hosted, and following a lot of scoping and exploration, we undertook a phase 3 part of the project that we're currently in just now, in order to bridge with an academic department and the University of Edinburgh. So we are really fortunate and delighted to be working with the University, the School of Health and Social Science. Our wish is to publish data that we have gathered from phase 1 and phase 2 of the project, and to establish further plans to enhance the evidence base for Scotland. We really need to scope ways of increasing capacity for FASD assessment, diagnosis and training via formal collaboration with the university, who are experts in education. And we also want to link more formally with our partner organisations, particularly FASD Hub Scotland. We are desperately needing to scope out new models for enhancing the breadth of expertise in FASD, being able to have more availability of expert level consultancy, enhanced level knowledge about FASD to support the confidence of clinicians and practitioners working in this area. So that's something that we're going to be working on, and we want to continue to support national level work in the Children and Young People's Task Force, for example, looking to support pathways to be built for FASD diagnosis and support to be considered. So just to give a brief overview in a schematic way of what I've discussed so far, we've had the phase 1 pilot, the national remit, and then phase 3 is the bridging, and we're currently looking forward to phase 4, which is about creating capacity and enhancing knowledge. And just to briefly give an overview of the team, we would like to formally welcome Suzanne O'Rourke, who's Senior Lecturer and Consultant in Clinical Forensic and Neuropsychology, at the State Hospital and also University of Edinburgh. Myself and Sarah will be working alongside co-investigators, Ken Mcmahon, Matthias Schwinner, and also we are very blessed to have Lindsay in our team, postdoctoral research fellow, and Moira, who's chairing today, as our project advisor. This is going to be our structure, just to give people an overview, and you can see there the same themes of working in consultancy, research and training as being our core work. And we also are really glad to have Moira alongside us, who will be chairing our FASD reference group, who will be experts through experience, people who live with FASD and have our family members, our carers of individuals with FASD will be guiding us in everything that we do. And we also will have our sort of national steering group working closely with the FASD Hub Scotland. So we're very excited about this new structure, and we think it will work well for us in order to continue to provide consultancy. People will know that we do that on a one-to-one basis. We've also offered group support to practitioners and also provide an advisory role to different organisations, including government. We do have over 200 requests a year, so we are needing to explore new models underpinned by sort of implementation science to enhance this capacity and to do this better. And we're excited to announce that we'll be offering rotational one-year secondments with our team for consultant paediatricians and clinical psychologists initially, in order to enable people to have dedicated sessional time to upskill themselves and have our support in honing their FASD knowledge and confidence, and therefore being consultants in themselves to go out into that Scottish landscape and provide that hub and spoke support more broadly, because we need to enhance our reach. In terms of training, we're going to be recruiting a training officer to support us in this work, working as a team to develop an FASD competency framework that people can refer to, that there'll be an associated training framework that can guide people to the training that they might need for their stage of learning. And those training course materials will be developed over the course of the project. And that will include train the trainer events, national awareness raising, and we will be evaluating all of this as we go along. So we really look forward to hearing from people who are interested in this, and you'll see our email address on our slides. Please do get in touch. Just to give a brief overview, that we also want to develop micro-credentials, micro-masters courses, and that will span, this work will span all levels of a sort of competency framework, going from informed to the expertise level. And you can see how we plan to do this work over the coming years. Very exciting. And as is our research strand of work, which I'm fully committed to, you can see all the different papers that we're currently developing about parent-carer perspectives, health economics, professionals' knowledge, social worker perspectives. We've got lots of data, and Lindsay is working alongside me and really supporting me to get some of that data out to you in a published peer-reviewed format. And we will go on to do more protocol preparations for additional funding submissions in year 2 and 3. We do a lot of activity. We've got a publication just recently that you might want to have a look at, and we're very excited to be working with other universities in Salford, for example, on a FASD specific parenting programme. So in conclusion, and thanks, I just want to reflect and say that we've been on quite a journey over the last 9 years. We really look forward to our next phase and working with our new team members and with our partners. But I really want to just stop for a second and thank everyone that's been part of this team's journey. Sarah and I particularly want to thank all of those in Ayrshire and Arran who have supported us over the years, and without whom we wouldn't be where we are today. To all those who've worked in our team, and to the Scottish Government for your support so far. It's so appreciated. We have a tiny URL that you can note down if you wish to hear about our team and be in touch and receive updates. So do get in touch and be part of our journey going forward. Thank you again, and I hope I've not ran over time too much there. I'll hand back to Moira. Many thanks.
Thank you, Jen. You haven't run over time at all, in fact. Can we say to people, if they have any questions that they would like to ask Jen about her presentation, could they add them to the chat, so that we can at least make sure that's working? I was just thinking, Jen, that having spent some time working with people internationally, how impressed they are with what's happening in Scotland. And that I think it's really pleasing that the government are prepared to put their money, continue putting their money where, as it started with Maggie Watts and then Chris. What in your wildest imagination would you like to see in 10 years' time?
Oh gosh, now there's a question. I think for our team and just listening to those who have lived experience of FASD, it would be that these individuals are able to have their needs met in a more timely basis, that people recognise FASD, know the pathways and how to assess, not only diagnose, but provide that very useful brain profile of strengths as well as the challenges, so that people can get effective and early support. Because when people do have early identification and support in the right way, early enough, and I keep underlining that word early, because that's what the evidence is showing us, these individuals do really, really well, and the difference it can make to someone's life trajectory can't be understated. So I think that would be the dream, for us to have an evidence base of our own and to be working in our neurodevelopmental pathways in that broad sense, thinking about FASD as well as other conditions. That would be the aim overall. Yeah.
There's been a question, Jen, about the FASD parenting programme. Is that something you can speak to?
Yeah, so we are working alongside colleagues at the University of Salford, who have been, again, working very closely with our expert reference group, parents and carers and families who have been to parenting programmes, who have had sort of family work and support that isn't specific to FASD, and they have really helped us to understand what needs to happen to a parenting programme to allow it to be efficacious for them. And so we've co-created and developed a parenting programme that's now been piloted. The feasibility study has been done, and it's now going to be a randomised control trial of that, including Scottish sites. So we're really excited to be able to get an evidence base for that programme, hopefully, and see what people think. So it's been long awaited. The generic sort of programmes don't seem to work for these children and families, so we really ought to be doing something different, and we hope that this can contribute to that.
Thank you, Jen. Another question, I'm not sure about the clarity of this. Who will the training be aimed at?
So if I'm hearing, if I'm understanding the question about the training that our team will be offering, it's going to very much be about practitioners, thinking about diagnosticians, thinking about people working in health and social care partnerships. But it will be there'll be a staged level, and because of our planning in terms of developing a competency framework and a training framework, it will be much more structured, so people can see what's on offer, but also we can be working with our partners at FASD Hub Scotland, who also do training, and together have packages for people that are right for them, for their stage of learning, and a route for increasing competencies, particularly in diagnosis and intervention. So it's fairly ambitious. I know it sounds quite broad, but we really hope there'll be something for everybody who is working in this field. And I know that the Hub also do lots of other training for caregivers and education professionals. So together we really hope to work on that and have a really nice array and menu of options for people. I hope that's answered that question okay.
It has, thank you. And it really, I mean, Scotland really is now being seen as at the forefront of what's happening with FASD, thanks to the FAST team and the funding from the Scottish Government. And I think you really need to be congratulated on that. Thank you.
Thanks.
Okay, our second speaker today is Carolyn Wilson. Carolyn is the unit head of the Strategic Policy Lead for Child Health in the Early Years Health Services and Maternal and Infant Nutrition at the Scottish Government. And Carolyn is going to be talking about preconception advice, something that's really, really important. And we can get caught in looking at the mums when they're pregnant and looking at the babies, but actually it's a bit like looking further up the river and seeing the importance of preconception advice and making pregnancies safer. Carolyn.
Thanks, Moira. And sorry, yeah, I've just joined, so I just caught the tail end of the conversation. Is it okay? I've got some slides that I can talk through, just setting the scene about some of the work that we've been doing in government. Part of the points that Moira made and us understanding the importance of trying to get much further into the journey for particularly for women and children. We recognise the need to have more focus on what happens in the preconception period, and I'm sure those of you around the table will have knowledge of all the intergenerational effects, particularly of alcohol. But the preconception health and care action plan was trying to broaden out the whole sort of landscape, if you like, around preconception health. So we know there's lots of challenge around maternal weight and the impacts that can have on the health of the developing baby and the complications at birth. We know the importance of folic acid being taken in the preconception period, as well as the early sort of weeks and months post-conception. And we were just looking at a range of factors, and we wanted to make sure that the alcohol aspect of this, so the message around alcohol, was included in this. So rather than going down a sort of a singular path and trying to promote all these different things about nutrition and diet and exercise and mental health and all the rest of it as a sort of singular message to particularly to mothers, or to women of childbearing age, we wanted to try and bring that together. So we had a way of targeting, if you like, the message around pregnancy planning and what would need to be considered to have a healthy, happy pregnancy, and looking into the future, obviously, about the impact on child health. So we commissioned this through the subgroup of the Directors of Public Health. So it was a subgroup of children and young people, and Health Scotland at the time, which was a time ago, supported and facilitated this. So this work has been going on for a couple of years now, and it was progressing reasonably well up until February last year, and then something happened that stopped the world from spinning, and that then caused us a real challenge, if you like, to progress it, because actually a lot of the members of the group that were supporting this work had a public health background and worked in public health. So we tried a number of routes to move this on to get the publication out last year, and that unfortunately didn't happen. So although I'm going to talk about this, we still need to bring this together to ensure that the preconception and health and care action plan is as sort of holistic as it needs to be, and we have got input from all the relevant partners, because it's not just health that we're targeting with this, it's much wider than that, and we want to look at local authorities and services, and we want to engage parents. But we've done all the groundwork. We've got a lot of the information there. There's been a literature review, there's been key messages developed, and there's been some insight work carried out to just test, and I'll talk that through in the presentation, to test some of the concepts, if you like, because actually what we found was the concept of preconception was not meaningful for parents. Nobody really understood that concept. But we also wanted to talk about intraconception, so between pregnancies as well, and actually find out where we had routes to target women specifically, but also we want to include men in this as well, because they have a critical role to play, not just in supporting women to make healthier choices around some aspects of their own health, but also their own health before conception is something that is emerging as an area that we need to consider carefully. We don't want this just to be a sort of stigmatizing that, you know, it's all down to women and it's all women's fault if it doesn't go well. So I'm gonna see. Oh, it's actually moved on. So that gives a little bit of background, and we wanted to make sure that we were linking into the work of the new public health body as well. And the public health priorities, there were 6 priorities set out through Public Health Scotland, and one of the key ones for us certainly was the priority 2, which was a Scotland where we flourish in our early years. I mean, there's 6 of them, and a number of them apply here, but it was really trying to get that point that actually, if we want to have particularly children having the healthiest life, you know, long quality of life as well, we need to try and get further upstream and have an impact on aspects that we know can have a detrimental effect, not just in the early years, but throughout the life course, and some of them don't manifest themselves until later in life. So really trying to get as far upstream as possible. It's working. This is great. So we wanted to look at the mental and physical health and well-being of men and women during the reproductive years. So we wanted to, there was a lot of work or a lot of focus, particularly from a health behaviour point of view, that is focused on physical health, so diet, as I said, nutrition, exercise, but actually the prominence of mental health and the you know, where that can have a significant impact on the infant's mental health and the child's mental health over time, and trying to really get in to the groups where there was already an additional need, and trying to use this. We want to try and use this framework to try and, you know, target messages and services that are working with men and women to help them to think about preconception health and pregnancy planning as part of that, you know, support that they're getting currently for maybe addiction or, you know, specific mental health issues. So it was really trying to be all things to everything, and it has been quite complex to pull together. We do have a logic model that sets all this out, but it is quite complicated, and we can possibly share that, but it's definitely been a bit of a journey, but I think we've got to a reasonably good place. I think the other point to say is that there are a huge number of unplanned pregnancies, so that isn't the same as unwanted pregnancies. There's quite a lot of different definitions that play in there. We spent a lot of time thinking about the definitions, and The number of unplanned pregnancies is around about 50% of all pregnancies are unplanned. So the purpose of this framework was to sort of build some constructs that would help, different segments of the population to really think about their pregnancy planning. And we know that, depending on levels of deprivation and other factors, then the ability to plan pregnancies, if that information is available and commonly understood, is different, and obviously inequalities come into that quite significantly. So we need to find a way to have a sort of universal message around this, but also a more targeted component. So and this slide just picks up, as I say, that sort of working definition that it is a continuum of care. So it's about how the conversations evolve over time and when it's right to have the conversations about which aspect. And certainly, we know the role of alcohol in this, and alcohol in the population, is very prevalent, and obviously much more recently, women's alcohol consumption is something, of a level of concern. So it's trying to link all those different aspects together, but definitely based on individual needs. So I've already sort of picked up
Carolyn, just a couple of minutes left.
Oh, sorry. Okay, I've only got a couple of slides to go. So, so the lack of awareness of preconception health was quite interesting, and really that concept just doesn't mean anything to people. It's not that they don't understand some of the areas that are important to think about before you become pregnant. So, some of our sort of insight work gathered that, but certainly the concept of preconception was quite difficult for people to understand. So we need to look at different ways of explaining that. This is just the sort of vision and overarching principles, and as I said, it's about reducing inequalities and focusing not just on women, and trying to get into the earlier age groups as well, and seeing if there's anything we can do through schools as well, and really start early on with that conversation. So again, this is just sort of picking up on that, and we want to engage with a range of national and local organisations. So we've got a framework that we're setting out that we're trying to pull together, and as I say, that's been a bit of a challenge. I think realistically it's going to be nearer the autumn before we publish this, but we want to do a level of consultation on that before we publish it, so we can test actually how meaningful it is for people. But definitely engaging the schools is something. So I've changed this from autumn 2020 to autumn 2021, if anybody saw the previous presentation on this, but that's really how we want to work this through. So we're going to really focus on this again over the next couple of months, pick the work back up again and try to move it forward, because we absolutely believe this is a crucial part of the plank, if you like, around early years for children in Scotland. That is me.
Carolyn, thank you. That was really interesting and a very good description of what's been happening. A couple of questions. It seems to me one of the issues is that we have alcohol consumption being collected, alcohol consumption details being collected in different hospitals. It's all being done in different ways, and so in terms of comparisons for data and service provision in the future, is there any aim to try and standardize that a bit? What's happening with that?
Is that in relation to maternity?
Yes.
Maternity, yeah. So absolutely. So our so the Minister for Children and Young People is actually very clear that she wants to see something more consistent around this, and not just in terms of how that information is collected and and getting that consistency, but actually how that information is then shared to the health visitors and other services that are working with children, so it's available as part of the child's record going forward. So it's something that we're working on. There's a lot of opportunity there, because there's a single system that's used with the majority of health boards to capture booking information, and we're working closely with our maternity colleagues to try to establish, what and how that's collected, and then get that transfer of that data, or the availability of that data through to the child's record, or available, once the child is born, to other services, so it can be part of a historical record to reflect if there's any challenges with children's development, etc.
Thank you. I think that would be really useful, and I think for me, just to be linking in so that we can even link the child's educational development, because so many of these young people are actually identified through early years at school. Carolyn, thank you. That was really interesting and informative. Our next speaker is Patricia Jackson. Patricia is consultant paediatrician. She was also co-chair of the SIGN group. And Patricia is going to be talking about the SIGN guidelines today as a diagnostic pathway. Again, a very innovative action for Scotland. Patricia?
Hi, Moira. I'm just trying to get the presentation up so that I can share it with folk. Basically, my remit today is in a very short time to try to synopse a lot of work that a lot of people have contributed to. I'm hoping that those of you who are non-health service folk will not find this a turn off because we're talking about a diagnostic pathway, because I think, as we've already discussed, if the SIGN guideline is going to make an impact, it needs everybody working in any child-related service to be aware of it and hopefully to use it in order to benefit the children and young people that could obviously have better support if they had the diagnosis. So for my second slide, I've put on the reference for the SIGN guideline, and the slides will be available later, and you can go straight to read all the intricate details of it. But I've also put on the parent and carer booklet, which goes with the SIGN guideline. And that's really to remind me that although the basis of a SIGN guideline, which is the Scottish Intercollegiate Guidelines Network, is to provide clinicians with standardised approaches to assessment and diagnosis, their overarching aim is to improve patient outcomes. So it's really important that if a guideline is established, that it doesn't just sit on a bookshelf somewhere and nobody does anything about it. And the guideline needs to be living, as it were, with those people who potentially could see children with FASD who need to get into the diagnostic process. So what are the essentials for actually making a diagnosis? And I think the great thing about the SIGN group was that we looked at huge volumes of information, but we tried to come up at the end of it all with a simple explanation for people as to how you would make the diagnosis, and trying to simplify the diagnosis as much as we could. Anybody who, and I know that many of you on today's meeting are aware of the past research in FASD, will know that much of the complication comes from the number of different types of categorizations that there were for FASD. And I think in our SIGN guideline, we actually had looked at sort of 246 ways of describing FASD. And because of that, people weren't actually able to identify similar groups. And as Jen's identified already, it's really important that you're able to develop research that is applicable to the children and young people that we all work with. And in order to do that, it's easier if you've got a diagnosis that is perhaps not so detailed that it prevents people from sharing information. So the essential for making diagnosis, as I put on the screen, are, and this is the big one, and I see already on the chat line, this is the challenge for all of us, how we get a better history of prenatal alcohol exposure. And in my view, it shouldn't be focused on when you're pregnant asking about alcohol. We should, as Caroline had indicated in her talk, we should be looking at alcohol as a health risk for women generally, and therefore that this should be recorded. And from children's point of view, it's a health risk for them, so it's an important bit of information, just the same as if your parents were smokers, we should be recording whether either parent took alcohol, as it were, because it can be detrimental. So you need a history of alcohol exposure. You need to have a neurodevelopmental assessment, which indicates, as it says, an impairment of greater than 2 standard deviations. And I'll show you a schema that kindly Jen had put together about the different neurological areas of assessment. And you have to have impairment in 3 of those areas. And then there are practical things that usually it's only paediatricians or trained paediatric nurses who will do, which is the measurement of the sentinel features. But I hope you'll see that although these need to be done, this is not the critical bit about making a diagnosis. The critical bit is having good neurodevelopmental assessment, and that involves multi-agency working, and that's why everybody needs to be contributing to the assessment of the children. Looking at the actual medical assessment that needs to be done, this is the reference is the bit that you find it within the SIGN guidelines. So it's 3.2 recommendation 3.2.1, as it were, and that's just the mnemonics that are used. But the diagnostic process you will see is exactly the same as it would be for any neurodevelopmental disability, and in fact for any paediatric problem. You take a good history. In this case, you're wanting to get a robust alcohol history, and I know that there's been chat about, how do we do that, and trying to get a regulated way of doing that, and that's something that we definitely need to aim for the future. Once you've taken the history, you need to do the examination as you would for any other child, growth parameters, head circumference, and again, in terms of the alcohol side of things, as you would if you thought this person had perhaps a sodium valproate toxicity, or if you thought it was a genetic disorder, you would look at the facial features and you would examine the child. And you need to think in all cases whether there perhaps could be a genetic cause for the child's neurodevelopmental problems. So really what I'm describing here is very similar to what you would do for any neurodevelopmental child. The things that you're particularly interested in if you're thinking about FASD are going to be alcohol and also facial features. Now, I think a lot of people worry that the facial features might be difficult to actually identify, and I've just shown you here that there are charts, standards, ways of doing this, and increasingly people are looking at the reliability of using facial recognition software, and there's a nice project team in Oxford who've been working on this, and I think they're going to come up with a relatively cheap way of being able to routinely measure three-dimensional aspects of a child's facial features by using facial recognition software. But at the moment, you can do it very simply with a little ruler, as it shows here, and this shows you how to do it, and you can compare with the charts that there are for these measurements. The other thing that we look at are lip thinness and smoothness, and again there's some lovely charts that have been provided by Susan Astley from the Washington group, and these are freely available so that clinicians can actually download them on their phone, and they're able to look at whether the child in front of them has any of these features. But I'd really like to emphasize that in fact facial features are a relatively minor part of the fetal alcohol spectrum disorder world, because only 10% of children will have facial features. And I think for too long we've got stuck on the idea that if you don't have the facial features, you don't have the effects of alcohol, and that is absolutely not true. You do require to have the neurodevelopmental problems. So this, as I said, she gives you a schema of the things that you need to test, so living skills, focus, attention, cognition, etc. And I hope that whatever profession you're working in, you will recognise that you can contribute information about these areas of function for the child. And we need to get better at collecting together the information in a way so that we can assess the kids, because people are already identifying on the chat that in fact it's very difficult to maybe get the time to do all of this yourself, and therefore we need to be looking at how we use each other's skills. And I'm delighted that Stephen is going to speak later about the national pathway and how we can use skills to assess children with neurodevelopmental problems. So children with FASD may have a patchy type of profile.
Patricia, sorry, just a couple of minutes.
2 minutes, that's fine. But you have to consistently make sure that there are 3 or more affected brain areas. And the other thing to note is that there's high variability, so they're not all going to be the same pattern. This is the algorithm which you would follow for FASD, and I don't have any time to talk through it in any detail, but basically you need to decide whether there is exposure prenatally to alcohol, so it's critical we have a good alcohol history. You then have to look at whether the person has sentinel features or does not have sentinel features. Most children will not have sentinel features, so they will require to go down this route, look at whether they fulfill the CNS criteria, in which case they fulfill the FASD without sentinel features. If you have sentinel features, then you would go down this route. We always have to remember that there will be those who don't have sentinel features, do have an alcohol history, but don't meet the diagnostic criteria, and those who are absolutely clear that they don't have an alcohol history in pregnancy and will not fulfill the diagnosis. And we will be left with some at-risk characteristics. But I hope some of you who are going to make the diagnosis would take more time to look through that and to follow it, because it's very helpful. In terms of getting children through the pathway, as I've said to you, I think this should mirror the type of pathway for any child with a neurodevelopmental disability. There is some specific ideas on the Scottish Government website about how to get children with FASD in and out of their diagnostic pathway, but again, I would leave you to look that up for yourselves if you have further interest in this. So the benefits have given us a guideline that is evidence-based, that people should be confident to use. We've simplified the terminology so that it's FASD with or without sentinel features, and this allows us to enter the research world internationally so that we can combine research results with Canada, Australia, New Zealand, who use the same type of descriptions. I think we learned a lot that this is about multi-agency collaboration in terms of trying to make the diagnosis. And also the sign guideline does provide information which Jen and the FAST team have extended hugely in order to provide information and sign people to appropriate resources. But hopefully it will provide us consistency initially in actually having children who the diagnosis is clearly and confidently made. So what are the aims? And I'm just going to end on this. We want to increase...
Talk fast, Patricia.
Yeah, we'll do. Increase public and clinician awareness. We really need to ensure better diagnosis, and the sign guidelines should facilitate that. The big aim, though, is better support, as Jen has already articulated, that if you're able to diagnose, you're able to support families and their children, and also ameliorate secondary difficulties. The recognition, I think, of long-term support also needs to be recognised, and as I said to you before, stimulating research. So the challenges moving forward are that we really need to get heightened awareness, we need to normalise recording of alcohol, we need to make sure, and this is part of what all of you can help us with, refer children appropriately, but then there have to be assessment pathways, and as somebody suggested on the chat, there has to be the facility and resource to actually implement those pathways in all health boards. And we do need to make sure that parents and children think we can make a diagnosis and make a difference to their lives rather than seeing it as a not helpful thing. Because I think there's huge evidence now the potential educational gains and preventative impact that the diagnosis can have for the child or young person. or even at adult level. So my apologies racing through. I hope you get a chance to reflect back on the sign guideline through the link. Happy to take any questions that people might have.
Thanks, Patricia. I'm sorry, we've run out of time. We don't have I don't have time for you giving answers to the questions, but I'm going to give you a couple that might be quite interesting just for people to hear, if nothing else. Questions on the availability of diagnosis pathways across Scotland. Is there a postcode lottery? And should screening for FASD be carried out as part of LAC health reviews, acknowledging, as we know, the higher number of children affected by PAE and care experienced communities? I'm really sorry we don't have time to get you to answer these, because I know you'd answer them very fully.
Don't worry, I'll do it on the chat line. So,
oh, that would be fabulous, Patricia. Thank you so much. Thank you for that.
Thanks a lot. Bye for now.
Bye-bye. Thank you. Our next presentation, Ali Brown and Barbara Aungston are running our next session with Gemma Manning and Paula Mcmahon. Ali now leads the FASD Hub in Scotland team, and she and her husband have 3 adopted children with PAE FASD. Barbara is an FASD advisor in the FASD Hub. She is an adoptive parent of 2 children with prenatal alcohol exposure. And they will be talking with Gemma Manning and Paula Mcmahon. This is the first part of a 2-part in the conversation section. The second part will take place in the final session. The title of this presentation is the FASD Hub Service Development.
Thank you very much, Moira. I've just seen something going round and round, so I hope I'm not going to have technical difficulties as well. But my name is Ali Brown. I am the project manager for FASD Hub Scotland. Could somebody confirm that you're able to see the slideshow? Yeah, perfect. Yes. Thank you. So I'm just going to take around 10 minutes just to give you an overview of our service, how we've developed and the achievements we've made in the last 20 months since we've been in service. How did it all start? Well, Adoption UK has a presence in Scotland now since 1997. We have an office based in Edinburgh, but a network of volunteers, supporters and staff that cover the whole of the country. And the nature of FASD means that, as was mentioned in just a moment ago, the high prevalence amongst care experienced children and young people, that many of those families that we've been supporting for the last 24 years have actually got children in their care who will have been exposed to alcohol, whether an FASD diagnosis is in place or not. So Adoption UK held 2 significant events in 2015 in Glasgow and then later in 2018 in Edinburgh, where we were really delighted to have Raja Mukherjee speak as one of our guest speakers, but also Sarah Brown from the Fetal Alcohol Advisory Support Team. And Moira was the chair that day as well. Following that, we worked with Scottish Government colleagues with Carolyn's team, and we're able to facilitate some focus groups with parents and carers around FASD, their experience of parenting a child who'd got that prenatal alcohol exposure, which led on to a report that was written as an outcome of the conference in May 2018. We were then delighted to be asked to invited to submit a proposal in the winter of 2018, which was asking for how we might go about providing a support service for parents and carers with FASD. And so we were successful and the hub was born, if you like. I'm not sure if you're seeing my, could somebody just confirm that you're seeing my screen advancing?
Yes, we are.
Yeah, right, okay, that's great. So, as I said, the hub was formally launched in June 2019, which was part of the Manitoba training that Jen made reference to earlier. We are part of the wider Adoption UK family. The Adoption UK in Scotland manage the FASD Hub, and it's really great to be part of something that's been around for 50 years. That means that we've got a lot of resources that we can draw upon. So our service itself, we offer support to all parents and carers. So that's adoptive parents, kinship carers, biological parents, foster carers. For children and young people where it's known that they were exposed to alcohol during pregnancy or may have been. So this is a kind of before, during and after. To use our service, people don't have to have that diagnosis, but that would be something that they would be thinking of or suspected. And you know, there's reasons, there's always already been in the chat there about why somebody might not be able to go on and get that, but that doesn't limit them from using our service. So we run a tiered service, and I'm going to talk about that a little bit more in detail as I go through my slides, but it's a 3-tiered service so that at all different points people can engage where it best suits them. I just wanted to highlight the benefits of being part of that wider team within Adoption UK and how that's actually helping to shape our service as well. So as I mentioned, we've got 24 years of experience in Scotland, 50 years across all 4 nations of the UK. But specifically in the Scotland team, we're really fortunate to have the benefit of having TESA Scotland, which stands for the Therapeutic Education Support Services, and we're able to draw on that team in particular for a clinical psychologist, but some of the other enhanced therapies that we're able to offer our families through our Tier 3 service. And we're also really fortunate from September last year, along with FAASD Scotland, Adoption UK took on responsibility for running a kinship care service for the whole of Scotland. And so that's meant that, again, there's been a bigger crossover between the FASD Hub team and that team, which is benefiting families. You'll see this slide and think, oh my goodness, there's loads of them. Well, there are 10 of us, but we all work part-time, and it actually equates to 3.4 people in a full-time number of staff. So there's many of us, but we're all kind of, you know, working at lots of different hours. But this does mean that we've got a huge breadth of understanding. Everybody on the team are adoptive parents, and that means that we bring that kind of knowledge and experience and lived experience with us, and everybody has either children who have got an FASD diagnosis or have got that prenatal alcohol history. We're really fortunate that we've recently just been able to add to the team with 2 FASD advisors who are actually qualified teachers as well, which is really helping us with our development of our training. So I'll just take you through our tiered services. Our Tier 1 service is basically a helpline, which is open 3 days a week, manned by our FASD advisors. Anybody can call that helpline who's got an interest in FASD, whether it's that you're a parent, carer, a teacher, social worker, third sector charity, you know, case manager. We even get calls from paediatricians who are wanting to refer people in, and that's fine. We're happy to speak to anybody. Okay. Oh yeah. So since we started in June 2019, we've had 271 interactions through our helpline service. We also have a website where you'll find lots of information, resources, signposting, resources from ourselves as well. We've produced 10 fact sheets, which are now available, some online, some through the team themselves. And we also have a wide kind of presence in social media, and also a YouTube channel where we've produced lots of little videos where we've recorded sessions that we've done, so people can go there and get that information as well. In our Tier 2 service, this is where we start, if you like, getting the interaction with individual parents rather than it being something you'd read on a screen. So we have a peer support group, which is a closed Facebook group. This is open to all families, all biological, adoptive, foster care and kinships. We actually have now just over 250 members within that group, and it's a very active group. we run through that group, a fortnightly virtual meetup. We've been doing that since lockdown. Would have been something that we'd like to have done in person, and before we all were in this world we're currently in, we did used to meet for a cup of coffee, but we've been doing that online, so that's really well attended. We've had 132 people attend that since those sessions since March, and they're themed around different areas. This is one that we did here in November, which was around sensory, and it's an opportunity for parents to come and speak to, you know, somebody with a lived experience as well, but with that other added knowledge. We also, within our Tier 2, have a one-to-one support service. This is where parents and carers can self-refer or can be referred in by a support worker, and they can get a one-to-one support from one of our parent partners or one of the FASD advisors. The type of things that we're helping people with is a lot of stuff around managing their own behaviour, not their behaviour, but managing their child's behaviour, but managing their responses as well. So a lot of, you know, what we do as parents, we can sometimes escalate the situation. So it's helping parents to navigate that. Lots of inquiries and support around school and education, and obviously the diagnostic journey that people go on as well. We've been able to support through that service, and that's a very, you know, could be a phone call once a week, it could be meeting up virtually once a week. So we've currently supported 26 families through that service. We also provide training for parents, carers and professionals, and professionals would be teachers, social workers, third sector organisations who are working directly with the family. We've had 29 of those training sessions that we've run with 553 attendees, which is just amazing really, when I think we just started 20 months ago. So we've developed 2 bespoke training, an hour and a half of introductory training, and then our kind of 3-hour session of what is FASD. During FASD Awareness Month, we also put on 5 individual webinars, which was working with some of the colleagues that are here today, and that was fantastic. We had 316 attendees over 5 sessions. Alongside this, we've also delivered 4 service information. So this is where people get to talk to me about what we're doing, how have we set up the service, and we've delivered that again to 220. So our Tier 3 service is where we are able to then provide more enhanced therapeutic support. So those 26 families who've been through our one-to-one support, some of them have been able to then go on to have that session with a clinical psychologist, access occupational therapy, provided some couple counselling, and within our therapeutic services we've got access to quite a large array of enhanced therapies that have been linked in through that TESA team that I mentioned before. The therapeutic element, the Tier 3, is due to funding restricted to adoptive, foster and kinship families. And since November, we've had 3 families that have gone through that Tier 3 and been able to interact and have that session with the clinical psychologist. So one of our other key elements is events, publicity and our public profile. Obviously things like today, working collaboratively, particularly during Adoption Week, because we sit within Adoption UK, and, you know, just recognising that a lot of the families that we are supporting have got children that have come through the care system. So we did 2 sessions with 133 attendees at that. We also really take part in the FASD Awareness Day, which is on the 9th of September every year, and we have a whole campaign last year that ran throughout the month, which was around I Can, really celebrating the successes, because there are successes and there are achievements for all of our children. And during that month, we were really pleased to be able to have or hit 1,000, or we're on beyond that now, of Twitter followers. We've been working collaboratively with Strathclyde University, which has been absolutely fantastic, and we now have a PhD student, which we're helping to part fund. So the PhD that's being undertaken is an understanding and determining of resilience in biological, adoptive, foster and kinship families who are living with fetal alcohol spectrum disorder. I just put up there the context for the study. If you wanted to know more details about this, then please do get in touch with us. But we're really grateful to have Samantha on board with us, who's the PhD student. We hope that basically, sorry, I should have gone back there. The key aims are that we will see at the end, we'll be able to explore the coping strategies and development of families and how, there's any barriers in relation to that, develop some tests, a key model of individuals' structure and determinants, and to engage with the UK wider community of experts on FASD families. So again, it's really great to have these links in with research and be able to take part of that. And our collaborative working, as Jen mentioned, we're really pleased to be able to be supported and to be able to link in with the Fetal Alcohol Advisory Support Team, and very grateful for the Scottish Government for giving the funding to our service to be able to deliver and support all of these parents that we've been working with. We're also really grateful to have links in with people like Miranda, who's speaking later today, and looking forward to supporting her in her PhD. Also with Joshua, and who's from Fife, and the clinical work that he's been doing. Again, he's going to be speaking to you about that. But we've also been working with some other third sector organisations, so Visibility Scotland. We're looking to do some fact sheets with them about how FASD and eyesight are related. I've been working with the Scottish families affected by drugs and alcohol, and really pleased to have joined their recently developed group around alcohol awareness. And more further afield, we've made a great connection with Jeff Noble, who's from FASD Success in Canada, runs a podcast, but also provides training directly and support to families, and we've been benefiting hugely through that connection. So our further developments, we're looking to have another kind of bespoke training programme around insights and strategies, and also with our educational advisors developing a programme that we'll be able to deliver directly into schools, but also developing more resources, fact sheets, and looking forward to seeing how we might be able to do that and connecting with such as Education Scotland. Coming very soon, we will have a Scottish network established, which is purely to bring together third sector organisations who have an interest in FASD. They might not be, might not be within their name of what they're doing, but that's their client group. So that is to come this spring, and we are really pleased to be able to announce that we are going to be establishing an online community for adults with FASD, two fantastic adults with FASD, one of whom is going to be speaking later today, will be helping us facilitate that. So what do people say about us? They say nice things generally. We're really grateful, but I think for me, it really makes my heart sing when I hear parents, and we're going to hear from two great parents in a moment, but people who have used our service and that's made a difference in their lives, and that's really what we're here about. So thank you very much for listening. I will take some questions. Hopefully we've got some time. I'll leave our contact details up while we're doing that. And then we're going to hear from Gemma and Paula, and Barbara will be leading that session, as Moira said.
Can I just check, Ali, whether you said you can take questions just now, or do you want to wait
that's
till
fine,
the end? One, I just want to make sure there's time for everybody. Have you noticed an increase in calls to the Hub helpline since the COVID lockdowns?
If anything, we've noticed a decrease in actual phone calls since the COVID lockdown, but what we have seen is a massive increase in people engaging with us through social media and joining the peer support group, and then joining and engaging virtually. So it's been quite interesting that those sort of calls have dropped, but people have engaged in completely different ways. I think everything's moved online and people have got used to this virtual world and feeling comfortable with it.
And maybe a bit of a sense of more privacy, or a sense of anonymity if people are still feeling anxious or uncomfortable.
Yeah.
Thanks, Ali. you want to just continue with the presentations?
Yes,
Thank you.
Yep, hopefully Gemma and Paula are there and they can turn their cameras on. We can see them. There's Paula. Right, going to speak to Paula first of all. Moira, you need to keep me right for time because I think we've only got about 3 minutes left to speak to both, but we might have to go over a little bit.
Yeah, well, we have the comfort break, so we've got a bit leeway. So
a wee bit of leeway. Right, so do we have Gemma? Your Gemma's.
Yes, I'm here.
Oh, you're there. That's fine. I see, that's fine. So Gemma and Paula are both caregivers of children with FASD, and we're very grateful that they've come along today to share their experiences of parenting a child with FASD and negotiating their way through diagnosis and beyond. So going to first of all speak to Paula. We've got some questions for you, Paula. So first of all, I was wondering if you could just introduce yourself and tell us a little bit about your family.
Hello everybody, thanks for giving me the opportunity to speak to you today. I'm Paula Mcmahon and I am a parent of 2 beautiful children, one birth child aged nearly 15 and my wee adopted son who has FASD and he is now 11 just a couple of days ago.
Okay, and what's been your experiences of parenting your children?
It's really difficult actually to put all those years of complex, challenging parenting that's very rewarding into like just a few sentences, but I'll try my very best. As I say, it has been really complex and it has been really challenging, but we've got lots of happy stories and lots of happy endings that have come out for the fight to advocate for our wee boy. He's a lovely wee boy and he's funny and very caring and kind, but from the moment that we adopted him or he came to be a part of our family, he was very, very dysregulated pretty much all the time, very, very hyper, hard to settle, hard to soothe, and a real significant feature for him right from the beginning has been really significant violent challenging behaviours. So when he was younger, obviously it presented slightly less of a challenge because you could pick him up, basically. But I think as he has got older and the violent challenging behaviours continue because he's distressed or his needs aren't being met, that's presented a terrible challenges in terms of safety for him, my other wee girl, keeping in mind that she was only 5 at the time when we adopted him, and the impact of living with that, the extremity of that on a daily basis has taken a terrible toll on us all actually, and it has been really, really hard to manage. One of the most significant features for us was he was in a mainstream school and he was trying very hard to self-regulate through the day. You could see him doing that, although he did find it really difficult and did have lots of sort of issues with his peers. So school had kind of dealt with that by, you know, finding other ways for him to spend his time rather than mixing with peers, which wasn't ideal because it led to quite a lot of social isolation. But the significant feature was that after trying to self-regulate all day, he used to blow as soon as the school bell went. And sometimes it would be hours and hours and hours of violent challenging behaviours where it was difficult even to get him to eat something. And it was really distressing to watch because he was clearly really distressed. Now, there was a distinct lack of understanding from health, from professionals, not so much health, I must say, it would be more social work, about why a child would be so distressed and at home, but not be presenting in exactly the same way at school. So my understanding through the support of CAMS at the time was that that's really common in all children that have got neurodevelopmental difficulties. It's something that people are familiar with. But there was a real lack of understanding about FASD and about, you know, why children show distress in that way and why they're not the same in different settings. And that Sorry.
Just to move you on a little bit, you're sort of saying there about there's a real lack of understanding from services around you. Could I ask you just to move on a wee bit and talk about the hub and the experiences that how you came to be involved with the hub and the support that you found there?
Of course. When we started with the hub, when it was first launched actually, and the hub experience was really positive for us right from the beginning, because we got a lot of moral support. I got a lot of one-to-one and group support, and given me particularly the confidence to be able to fight for Kieran and advocate for his needs. And that was really helpful. But it also was good as it put us in touch with other experts who were able to contribute to identifying what Kieran's needs actually were, and ultimately leading to making sure that his needs are now met and he's a very happy wee boy. So it really has been absolutely life-changing, because we got our child into a special school with really the support and the education and the resources provided to us by the FASD Hub, and it really has completely transformed his life. Now his needs are met and the violent, challenging behaviours have all but stopped.
That's great. That's great to hear. Kashi, just in one very short sentence, you've got all these people listening today. There's nearly 200 people listening today. What is your take-home message? If they leave only knowing one thing today, what would you want that to be?
Well, I would like, my ultimate aim is I would love every professional to understand what FASD is and how and what it means, but also as well how that can sometimes present in violent, challenging behaviours if needs aren't met, and how to understand the impact of that situation on the child and on the rest of the family.
Yeah. Okay. Thanks very much, Paula. Thanks. And if I could ask Gemma.
Barbara, just a couple of minutes.
Yep, Gemma will speak fast. Gemma,
yeah. Sorry, I hate to do this.
No, I know, I'm really sorry. I think it's really important that we hear this lived experience, so we'll try our best to cram it in. But Gemma, if you could just briefly introduce yourself, tell us a wee bit about your family and just a little bit about your experiences.
Yeah, so my name's Gemma. My husband and I adopted our wee girl when she was 8 months old. She's almost 7 now. She's 7 next week. When she arrived, no history of any drugs, alcohol, nothing to worry about. Absolutely perfect baby. And then things changed very quickly when she was about 2.
And what kind of experiences have you gone through as you've been parenting her? What are some of the signs and symptoms of FASD that you've experienced?
They're long and complex, but I'll try to bullet point them. The main one is aggression and violence, and it's strange, like listening to Paula talk about it. There's lots of similarities, and when you're using words to express your child being violent towards you, obviously there's this. You can't put across like how devastating it is. I mean, just this morning, getting our daughter dressed for school, I have bruises, pinched hips, slapped, kicked, bitten, spat at, pulled hair for getting dressed, and that's kind of been the main one ever since she was 2. And as Paula said, when she was little, it was much easier to deal with. Now, not so much. But other things like strange sensory habits that she's got. So to say she's a picky eater is an understatement. She feels sick a lot of the time. She doesn't have any empathy or much understanding for social situations. But the main thing about our daughter, which makes it kind of more difficult, I think, for us, is that she only displays these behaviours 99% of the time at home.
Yeah,
so
that seems to be something that we're hearing quite a lot of.
So we thought it was us for a long time. We turned into these, super nanny, timeout obsessed, reward chart obsessed parents, and our behaviour just got worse and worse and worse.
And you're now very much involved in the hub because you're a parent partner working alongside us, but I'm going to gloss over that because we're running out of time. But I just want to finish on, if there's a lot of people here today, what is your take home message? If they leave here knowing one thing, what would you like all these people here to know?
That it's not actually about changing their behaviour. It's about viewing their behaviour not as naughty behaviour, bad behaviour, challenging behaviour. It's viewing it as symptoms of their disability. And when you look at it through that lens, through that filter, instantly the child before you changes from the aggressive, willful, cheeky, angry child to actually a very scared, anxious, overwhelmed child, purely by looking at it through the lens of disability symptoms rather than behaviour.
Okay, thanks very much, and thanks Gemma and Paula. It's
No
so
worries.
important that lived experience is at the heart of what we're doing in terms of FASD in Scotland. So thank you very much for sharing your experiences with us today. Thanks, Moira.
Thank you, Barbara. Thank you, Paula and Gemma. Lots of positive comments about the importance and the helpfulness of hearing from parents. And interesting, Gemma, even you connecting with some of the things Paula was saying, in that sense of not feeling so alone with it, that other people are experiencing it and it's not your parenting, it's the situation and the dynamic. Sort of don't try harder, try differently. See fear, not anger, and that changes people's response so powerfully. Thank you everybody who's been contributing this morning's session. We're going to have a short break. Remember, don't take us to the toilet with you. We'll get back, I think maybe just about 11:10. And that we should still be able to get on track with that. So take a break, everybody. See you back at 11:10. Thank you. Welcome back, people. 11:10, and we're going to start on time. Our next presenter is Fiona Mckinley. Fiona works in the Improving Health and Wellbeing team of the Children and Families Directorate of the Scottish Government. And her presentation today is on FASD e-learning. Fiona?
Thanks, Moira. I guess today I would just thank you for inviting me to start with. It's really great to be here to hear everybody's thoughts on FASD. I think the background to the e-learning, if you could, hopefully you can all see my screen. This is the screen you should go into when you actually log on to the TURAS Learn, which is where the e-learning is situated on the Education for Scotland website. I mean, to go back to the beginning, that the e-learning was set up to help understand more about FASD. So in partnership with experts, we created the e-learning module. We brought in an external company to do the design work and make it easy to use, hopefully. And it's set into 4 different sections. So once you're in, which I understand, you know, you do have to put a login and then you get in, but once you're in, you are actually in and it is free to use. It's into 4 sections. So there's the starting bit that tells you how to navigate, and then you begin the resource, and there's 4 sections: understanding FASD, preventing FASD, identifying interventions and support. The beginning gives you the key to the icons that will pop up to make it easier for you to navigate. Given that this is quite a complex area, there is quite a lot in PDFs, so that the actual screens are quite easy to see. But actually, if you're interested in looking deeper into the issues, there are PDFs that are downloadable and that you can print off to look at your leisure. So the starting there, and then you just need to click on each icon as you are interested. I mean, understanding FASD is an overview to help understand why preventing FASD and knowledge of the CMO message on no alcohol, no risk in pregnancy is so important. It also outlines why early identification is essential and the need for intervention and support to improve outcomes for people with FASD. So if we just click on understanding, what you get is at the start, you get a run through about what you should expect from completing this section. And then you just click on continue, and it runs you through the different things that you can look at. So the myths that people think around FASD. And then if we move on, you can see there's different pages that will help you, and you just click through. And if it comes up with that, you get more information that you can click on. So you can pick on the areas that you think would be most helpful to you at the time. So there's also case studies that hopefully give some sort of make it more real. And I really appreciated Paula and Gemma's presentation earlier. I thought that was really excellent, and thank you for sharing that. I think making it real for people is very, very helpful as we go forward. And then, as you can see, there's more selections of what you need to know, case studies, and then there's the thought bubbles of what you can sort of reflective questions for yourself that maybe you want to have an old-fashioned notebook almost to think about what you could have done differently. And then there's some knowledge checks as you go through. There you go, and you can, you know, pick your, and it gives you the reasons why you're correct. And then if you don't actually put an answer in, you have to complete a section. And then it gives you the reasons why you're correct or incorrect. So if I put true here and submit, it would say I've chosen an incorrect answer, and would give me the reasons why that was the case. There you are. And so you've completed that section. You can download the key messages if you find that helpful. And then if you find it helpful to print those off and maybe put up in your office, if anyone's ever back in an office, of course, you can use it for that as well. So then once you've finished that section, you then go and you have a tick and you can go into the next section. So you don't actually have to go through every single section. You can go into one section, you can come out and then come back in again and just work through what suits you and what is of interest to you at that time. So, and we have the Chief Medical Officer's Guideline on no alcohol, no risk, which links back to Carolyn's preconception work and the work that I think the Women's Health Plan is looking at with alcohol brief interventions, which this seemed to be a big issue. I noticed in the chat about mothers' alcohol history and recording that, and that is definitely something that, as Carolyn said, the Minister for Children and Young People is very interested in at the moment. Well, is very interested in, has been raised with her. And we're looking into that just now, round about BadgerNet, that is the system that records maternal history of various issues while they are pregnant, and how we look at that and how that is recorded and used in boards is something that we're looking at the moment. So yeah, there you are. And then it gives you more references and prevention. So you get, as you can see, as you work through, you get the introduction, early identification, examples, more information, places you can go for more advice, and some case studies which hopefully are very helpful to people. Okay, right, there we go. So is that quite helpful? I think for the e-learning, for us, the issue is making sure it gets into enough people who need it. And so any help that you can give us would be very, very welcome about making sure that the awareness that the e-learning exists is there and available for people as they need it. For us, next steps are around doing that. So we've got a collaboration with the Royal College of GPs who are going to use the e-learning to do some sort of continuous professional development for GPs and the practices, which I think will be very helpful in taking forward the maternal alcohol history and the importance of, when you're looking at contraception, alcohol is a big issue that women need to think about. When people turn up at their GPs and say, I think I have FASD, what what you need to do about that, what you need to do around that, and if you take your child to a GP, they will have more knowledge about FASD as well. So there's a full range of things. So that it's not just the GP, it'll be the full practice that will have this as well. So the nurse who is doing the contraception advice, if they are affiliated to, the health visitor is attached to that GP practice, they will have that advice as well. So I think it's helpful across the board, we hope. We're also, and I think Mary Ellen and Paula are on the call as well, who are taking forward work with Education Scotland around promoting this e-learning and what needs to go into schools around FASD. So that's a big piece of work that we're hoping that will be taken forward with them, and we'll take on board the lived experience of families and young people who are actually in education and what it meant to them, and what teachers and the education system needs to do to help them as they go forward. So I think really, hopefully it's a useful resource for everybody. The experts that produced it, we were really grateful to for their input. Obviously, it was a big piece of work, but hopefully it is helpful. But we need to get it out there, I think, more. And if you can help us with your networks, that would be great. If you have any feedback on it once you've had a look through it, that would be really helpful as well. We'd really welcome that. And if anyone else we can think of that needs to know, we would be very keen to tap into that. We've also, the social work education group are also very interested in it, so they are recommending it as part of their training that is appropriate for social workers as well. So there are different bits happening, and I think it's just a matter of moving on with that. So
thank you, Fiona. That's been really helpful and a very nice overview of what's happening. Can I just check how do you want people to contact you if they have comments, questions, helpful ideas?
If you just give them my email address, that would be perfect. I'm more than happy to have a discussion with people about what they think is missing, or what they think has worked, or what they think our next steps should be.
Great. Maybe we could put that on the chat bit, Lindsay, so that people could have it for Fiona in case they want to just...
I can put my email address in, actually.
Oh, that would be fabulous. You're a star. You're a star.
Well, I say that, but you know what? This is technology and me.
May the force be with you. I think that questions and things are probably actually better answered because of the chat line with some of the things you've been talking about. So if it's okay, and we can leave it with that, I think that would be a better way of I guess helping you to get the answers you want, and for other people to get the answers.
I mean, that would be great. I think we are really keen on, it took up a lot of experts' time to produce this, and they put a lot of effort into it. So we really want to promote it as far and wide as we can. We think it'll be a really useful resource for people. So anything we can do to do that would be really great, I think.
Thank you, Lindsay. I just get a feeling there's a perfect storm in Scotland at the minute, and it's wonderful to see, having spent many, many years on the outskirts of this.
I would agree, Moira. I get that feeling as well, and I think it is. It's excellent. Yeah, great.
Okay, Fiona, thank you again. Our next presenter, Lindsay Logee. Lindsay is a consultant paediatrician in NHS Lothian with a special interest in FASD. Her presentation is on thoughts about a clinical peer review group. Lindsay?
Hi, yeah, thank you. It is actually going to be mostly me talking rather than slides. I've got one slide to show you. I'm wanting to speak to you all, and I'm very pleased and happy to talk and float an idea. And to be honest, it's going to be something that hopefully people can put a lot of thoughts about into the chat. So the collaborative group around FASD have had the joy in the past of meeting in person. We had various meetings in various venues previously supported by the Scottish Government. And as part of that, we shared lots of learning and information, but we also had the opportunity to discuss some clinical cases. And that was incredibly important after all the training that we had to start to think about cases that we found tricky to assess both clinically, and often that's paediatricians, it's psychologists, it's allied health professionals. And I appreciate that there's a much wider group of people involved in the diagnostic assessment of children and young people with FASD. And I suppose COVID has made us think about different ways of learning. And we also realise that we don't have the opportunity to take out huge chunks of time of our day and travel across the country, etc. So we are wanting to float today an idea that we wanted to have a clinical peer review group and consider that as a way forward to help with both our own confidence and our capacity. And in particular, I pick up on the chat in the groups that has been about difficulties in getting assessment for FASD, and yet how important it is for families, children and young people to get that diagnosis when it's appropriate. So we are really keen and hopeful that considering a virtual online peer review group around cases would be a really good step forward. I hope that it would allow us in a way to share cases that are difficult for clinicians and for professionals, health professionals around the diagnostic assessment of young people. So although we have got the signed guidelines as Patricia's shown us earlier, and we've got so much from the FAST team and training opportunities, I think regular meetings of clinicians across Scotland would be really, really helpful. And that was our hope, that there was a way forward to assist and help people. So this is really me trying to float to everybody out there, and I'm so pleased that we've got so many people online that can think about this and what they envisage the way forward for this. There are obviously impacts on how we manage this, and part of that will be about anonymising information, confidentiality, etc., etc. And we have still yet to agree a sort of terms of reference around this at the moment, but we are definitely looking forward to the opportunity to take this forward. One of the issues that we thought you could bring along might be the cases that, again, people have talked about in the chat, cases where young people or children have got some of the sentinel features but don't have a alcohol history, cases where you're finding it difficult to find an alcohol history, cases where you're unsure about the neurodevelopmental brain domains and how they all fit together. Me and the team have thought very, very long and hard, and we don't want this to be a group that is run from the top down, but we hoped it would be a peer review group, a collaborative group, a group that learns together, where we have got senior people and people with a lot of experience on the team, but also others that start to bring in their own experience. But this would be a group for professionals rather than having any involvement from families. And the reason for that is to allow learning, to allow confidentiality around cases. So clearly that's something that we hope will then be really helpful to families. I'm trying to think if I'd forgotten anything else. I really only had the one slide because I was going to just do my usual, which was to chat away. I managed to bring myself out of the whole meeting in the process. But if you're happy to somebody to unshare my slide, then Moira, I'm not sure if there's any other chat going on that we could pick up on, or if we move on.
Thanks, Lindsay. It's a really important idea, and just as parents get so much support from each other, I think clinicians and health professionals need the same. You know, we all hear stories that that whether we like it or not, we end up taking home with us. And it's important to have somewhere that people can share this and learn from each other in a peer support way. Lindsay, it seems to me it's the sort of thing that people may want to discuss with you. And I'm just wondering how they could contact you if that's the case.
Well, obviously, if people leave messages in the chat, and I think the group, the collaborative group and the FAST team, we can agree a way to respond to that. I think we weren't sure about using the email address that people have used to link into the meeting today, and if people are in agreement with that, that if they send messages, we can get back to them. But this is a watch this space type of discussion today. We will definitely be bringing forward something more concrete for everybody to hear about. And I think it was really important that we had the opportunity today. And thank you very much for giving us that to sort of launch the idea and the thoughts about this today.
Thank you. That's been really helpful, Lindsay, and a very important issue. As everything moves along, we have to respect and look after the people who are doing the work in a professional sense, just as we vitally need to respect and look after the parents and the children themselves when they're doing the work and the development. I think the best thing would be to move on. We can have a look through the chats, Lindsay, and see if anything's coming up and how the best way of us dealing with that. So thank you. Our next speaker is Joshua Mcgulton. Josh is a clinical psychologist in the Learning Disabilities Psychology Service for Children and Adults at Lynnbank Hospital, NHS 5. What I do want to say to people, some of what Josh is presenting today is not yet in the public domain, therefore at this point can't go any further than the symposium. So Josh will tell you those bits not yet published. So please no screenshots. Let's respect this very important, frustrating, but yet very important point. Josh is going to be talking on the FNDQ, a developmental history taking tool designed with FASD in mind. Josh?
Lovely, thank you. So hopefully this will work. I've had some issues with my internet connection earlier today, so if I drop out, please do let me know. So I'm going to talk a bit about the FNDQ, which is a tool that I was tasked with developing within NHS 5 as part of kind of our thinking towards neurodevelopmental pathways. However, with all NHS projects, actually, there's hundreds of people involved, and I've just named a few of the teams and individuals here. So this certainly isn't all me, although I've had the pleasure of being able to kind of coordinate this and play a role in driving it forward. So kind of to set the scene, across Scotland, we're seeing this move towards neurodevelopmental pathways. And I think this is great news. I think it's going to lead to a more joined up approach. It's going to allow us to be working more holistically in multi-diagnostic, multidisciplinary teams. I think we're going to save children bouncing around between waitlists. And we're kind of recognizing the gap, the overlap between all these different neurodevelopmental conditions and actually thinking about a child as a whole, as opposed to do they fit into a certain box. And I think the process of doing this is going to help us better meet the needs of children with fetal alcohol. The problem we have is that all the tools that we currently have are what I think of as confirmatory assessments. So, for example, to take autism, for example, we have tools such as the ADI and 3DI ADOS, which really ask, what is the evidence that this person is autistic? They're looking at one particular area of development, in particular one diagnosis, and they're really good at that. But when we have a child coming in for a broad neurodevelopmental assessment, we can't give them an assessment for autism, for learning disability, for ADHD. We can't give them all executive functioning assessments and memory assessments. It would just mean barraging kids with all these assessments. So it doesn't make sense. What we need is tools that assess all of child development, not just one or two areas at a time. This tool doesn't need to be diagnostic. We already have great diagnostic tools, but what we need is a tool that kind of provides the context, that gets an overview of what's going on for this child and this family, and points us in the right direction for what assessments we need to do next. So this is almost a bit of an exploratory assessment. Another issue that we often come across is that multidisciplinary, while it's a great thing, can often mean multiple professionals taking the same developmental history. So this leads to parents repeating the same story over and over and over again. Often 90% of that story is exactly the same, and there'll be a few profession-specific questions thrown in. The alternative is, sometimes I'll get a referral which has what sounds like a really great developmental history, but they won't have mentioned alcohol use, for example. And I don't know then, is it that this person asked about alcohol use and there wasn't any, so they haven't mentioned it because it wasn't important? Or is it that they haven't asked the question? And so when we rely on other people's histories and we don't necessarily know what they've asked, we risk confusing absence of evidence with evidence of absence. So the solution that we've kind of come up with is the Fife Neurodevelopmental Questionnaire, or FNDQ. So this is a structured developmental history taking tool for neurodevelopmental disorders. It's multidisciplinary, so we've had inbuilt expertise from multiple different professionals and specialties, and it's holistic. So we try and look at all areas of child neurodevelopment. We try and consider what experiences and what environments has this child been in, and what's going on with this child right now. What are the big priorities? And importantly for parents, it's one single history that gathers all of the important information and that we then share securely online. So in Fife, we do that via the clinical portal. So anyone who's working with the child can access the child's records, which will include this. And so it means we have this single core shared developmental history. Now, the FNDQ is a data gathering and formulation tool. So it's not diagnostic. It doesn't churn out a number or a diagnosis at the end. And it's equally not a screener. It is a very long questionnaire. It's 38 pages. So it's far too long to use as a screener. But it does give you a history. It's a history taking tool. So it gives you much more qualitative information than a screener would. And it really gives you the basis on which to build a formulation, identify what kind of questions you have about this child, about their presentation, about their experiences. And so you can kind of work out what further assessment you need to do. When you've done that assessment, then also provides the context for those results. It helps you think about differential diagnoses, other factors that might be impacting your presentation, and then from that to plan intervention. It's also a tool that needs to be done jointly between parents and clinicians. So the way that I tend to use it, and I recommend people use it, is giving this questionnaire for parents to go away and complete what they can. And there are some bits which parents find quite straightforward. So like names and dates of birth of siblings and parents, for example. But they don't have to complete it all. Just have a go at what they can do, bring it back to clinic, and then we'll go through it. We'll review the bits they have filled in, and often I'll have follow-up questions. And then the bits that they weren't sure how to fill in, or they found tricky, or they just ran out of steam, then we review that together. It can also be used as a structured clinical interview, where I also recommend, even if it's the clinician filling it in, parents have a copy so they can see what's being asked. Or it can be sent out, returned, and then reviewed by a clinician with a follow-up phone call with parents. So we're now on version 1.4. Very brief overview of the structure. There are 20 sections to it. Sections 1 to 8 are what I call compulsory sections. So this includes things like current concerns, family history, pregnancy, medical history, educational history, those kind of things. Then the second half, the final 12 sections, are based on the Essence Q. And if you don't know what the Essence Q is, it's a screening questionnaire developed by Chris Gilberg. And it's quite straightforward. It kind of goes through 12 areas of development, including things like motor development, sleep, attention, hyperactivity. And it just asks, have you or anyone else had concerns for more than a few months in this particular area of child development? And so we've had permission to use those questions. And if parents answer yes or maybe, then we ask parents to complete the rest of that section. If they say, nope, that's not an issue, it means they can then skip the rest of that section. So that makes it, while it is 38 pages, it means that there'll be some pages that they can just skip straight over. Likewise, almost all questions follow a yes-no format with some space to elaborate. So for example, we ask about issues with handwriting. And if there aren't issues with handwriting, parents can just circle no, they don't have to write anything else. It's only if there's something going on that's worth us knowing more about that they need to write. So we're trying to minimize what parents have to do. We have created what we call the FNTQ Digital, which is a PDF form that people can type directly into. But we're also in the process of kind of working out how we could create an online version of the FNTQ so that we can, for example, automatically grey out questions that parents don't need to answer. And equally, if we had the right ethics and we had oversight of this, there's potential to create a massive public health data sets that we could use for research and for really identifying how many kids are there out there with these different difficulties and what are their needs, how do we best support them. So I think there's great potential there as well. Why is the FNTQ helpful when assessing for fetal alcohol? The FNTQ is something we use routinely when we do learning disability assessments, ADHD assessments, autism assessments in 5, but you can also use it with fetal alcohol. And I think one of the real strengths of this is that we've had expert input into the design. I'd actually go as far as say that fetal alcohol has actually been the largest group that have had input into the design of the FNDQ. So we've had great feedback from parents of children affected by fetal alcohol. We've had input from FASD Hub Scotland, who are also part of our stakeholders group, and they've provided really great feedback on what we can change, how we can make it better, think about how we can roll this out. And we've had lots of advice and feedback from Jen Shields, and I have spent many hours poring over the individual wordings of little questions to try and make sure we get it right. So big thanks to Jen. When you look at the sign guidelines for fetal alcohol, the FNDQ gives you information on most areas that the sign guidance looks for. It doesn't touch on facial features, and it doesn't touch on neuroanatomy, neurophysiology, but it has either questions that ask about, or it has whole sections on pretty much all of the CNS areas and alcohol exposure. Now, just because we have a section on, for example, language, it doesn't mean that this is going to give you enough to tick that area off when you're doing an assessment of CNS functioning, but it might tell you that this is an area that you're going to need to do a more formal assessment on. I think the biggest thing, though, is that the FNDQ asks about alcohol use in pregnancy, and it normalizes the fact that we ask this question, and it starts to embed it in standard practice. So it really highlights to clinicians who might not yet know that this is a question that you need to ask. And by making it standard practice, I think it makes it easier for clinicians to feel able to ask that questions, and also for parents to answer, because this isn't something that we're just asking them, it's something that we ask every parent when we go through this form. It also provides a structure to the questioning, and this is kind of what I've spent a long time with Jen in particular trying to really tailor. How do we ask questions about alcohol use in a sensitive way? And so we're really trying to focus on understanding the wider thoughts, feelings and circumstances that birth mum was experiencing, and really trying to focus on what she did do and what she did change rather than what she didn't do or what she couldn't change. But ultimately, the FNDQ is a tool, and like any tool, you need to know how to use it right. And I know that there's other ongoing work around training for clinicians on how to ask those questions. And ultimately, this is parents' information to disclose. Parents need to be ready to disclose this information, and they need to be able to trust us. You can't build rapport with a form as much as we try and make it as carefully worded as possible. And so this is why it's a tool for clinicians to use, but it still relies on them building that relationship with parents. So I'm going to show you some excerpts from the FNDQ. For copyright reasons, this is the bit that I'm going to ask you to not photograph, screenshot or record. That said, we are actually really keen for other health boards to use the FNDQ. We have 5 health boards using it across Scotland, and we've had really helpful feedback, what we need to change, what's worked well, what hasn't. So if you would like to use the FNDQ, then it's free for non-commercial use. It just requires a license agreement between NHS Fife and other health boards. So please do feel free to email me for details or for a sample copy to have a look through. So,
Josh, question for you. Could the FNDQ be used with community teams and neuro teams?
absolutely, yeah. So in Fife, it's used in CAM services, community paediatrics use it, sometimes speech and language therapists use it, sometimes epilepsy teams use it, and it's part of our neurodevelopmental pathways.
Can it be used for adults?
So at the moment, no, but our adult team in Fife are developing their neurodevelopmental pathway, and they're really keen to adapt the FNDQ. So I've partnered with one of their clinicians, and we're now looking at what can we change to make this suit adults better.
Thank you. There's an incredible amount of work has gone into this. And I think, although, as Josh was saying, a wonderful data set for research purposes, but of course, for any of us who do research, the whole purpose of the research is to improve service provision.
Absolutely.
And I think this will do amazingly well in terms of improving service provision. We've so long been into the, as you said, Josh, the absence of evidence. It is not the evidence of absence. Evidence, I got that right. And if we don't have the numbers, then the funding doesn't come in. If we don't have the numbers, we can't show people the importance of this and how it affects so many people and so many children. So thank you, Josh. That was, I really enjoyed that.
My pleasure. Thank you so much for having me.
Thank you. We enjoyed being had. Next presentation for us from Morag, Murray and Miranda. Yoda. Oh, Miranda, I thought I was going to get this name right, and I can't.
You're doing well. It's all right.
I keep telling her,
yeah,
that's it. I keep telling her to change it, Moira, but she won't.
No, don't. It's me that needs to change. Morag is an educational psychologist for the City of Edinburgh Council. Miranda is an educational psychologist also with the City of Edinburgh Council, but she's also working on her PhD on the subject of FASD at Edinburgh University. Together, they co-lead on FASD work, which is embedded in the Psychological Services Improvement Plan. And today they're presenting on FASD education resources. Well, as you can see, FASD educational development and resources.
Okay,
thank you. Over to you.
Thank you, Moira. And I hope everybody can see our presentation. And I have to say, it's lovely to see lots of my local Edinburgh colleagues and lots of familiar faces across Scotland that we've been kind of working with as well. So today we are obviously, Morag and I are going to give you an overview of key educational resources. And I think we're really mindful of our audience here as well, that we kind of recognise we've got parents and professionals. So we are looking to support individuals within the education system and how this could relate to parents and professionals' knowledge as well. Okay. So I'm going to start off with this slide, and it's a lovely infographic from FASD, the network of Saskatchewan, and it talks about being FASD informed. And I think this is really significant because it kind of gives us a sense of how we need to be informed for the children themselves. Children themselves need to be informed of FASD. We need to be aware of families' needs. We need to know what is helpful for schools and what is helpful for the professionals when they're working with individuals, families, and school systems as well. So it covers many areas, such as seeking out education, examining procedures, policies, offering individual support, building respectful relationships, and using a strengths-based approach. Now, obviously, on the right side of this diagram, we've got a lovely infographic that we've borrowed from the FAST kind of newest educator resource, what educators need to know about FASD. And this is the key bit that I'm picking up from lots of conversations about. We need to understand how FASD presents for young people. So we've got the 9 domains that are affected, which is executive functioning, sensory and motor skills, academic skills, brain structure, living and social skills, focus and attention, cognition, communication, and memory. And I think these are really important for lots of parents and professionals to understand, and individuals themselves, in terms of building those relationships so that communication is effective and that we develop a much more effective strengths-based approach as well. Okay. So on this slide, and I think it's really helpful when we're looking at FASD within an educational context, and others who are looking in and looking to support young people, I think we really need to emphasise that FASD is often presented as an invisible disability. We know that facial features are not kind of commonly part of the profile. It's kind of identified in a very small population. And within that, this necessitates a brain-based approach. And this really recognises, for schools that we have a neurodiverse population. And within that, we've got those individuals who are neurodivergent as well. And for, I suppose, educators, it's really important to be mindful that very traditional interventions that kind of in teaching that were based on the kind of more behavioural approaches of teaching and learning and more kind of social kind of learning theories as well, don't always work that way. And it kind of recognises that with a brain-based approach, we're recognising that FASD has a neurological impact on many different aspects of cognition, social, and there's kind of physical and social impairments as well. I'm using the word disability because we have to recognise that FASD is a lifelong disability. We might be aware of lots of other factors that are going on there in terms of physical health as well. But when something is a lifelong disability, we need to be really proactive rather than reactive and waiting for something to happen. We need to get those supports in at a much earlier stage. Now, from page 7 from the FASD Educator Resource, I've tried to highlight the kind of really helpful information here. And we've got all the domains. And actually, these are some of the kind of profiles, presentations of kind of individual children that you might see in a classroom. And I might say classroom, but it could be easily, an after-school club. It could be, kind of out in the community in kind of sports club, a dance club, all these kind of different kind of places where a young person is engaged as well. So we've got, for example, we've got executive functioning. So the young person may present with trouble with planning, sequencing, problem solving. They might be very impulsive. We know there's lots of kind of issues around their emotional regulation. They might find the kind of change between activities quite difficult. And obviously, we've heard from Paula and Gemma today, parents, lots of the kind of issues that we were talking about, kind of around behaviour as well. So there's lots within that slide that covers, and I think within the FASD Educator Resource, that really highlights to educators and also professionals, because it's obviously much wider than just one discipline here as well. Okay. Now, obviously, we're in the midst of an ongoing pandemic, so we have to recognise that. And obviously, we're on Teams today, so part of it. I mean, a lot of things have come out, obviously, on Twitter and social media about mental health, and that is right. We are really keen in terms of our own kind of psychological services. We put out a lot of psychoeducation around supporting well-being and self-esteem, and this is one of our kind of recent Twitter posts. And it just highlights the significance of looking at our day-to-day well-being and recognising that there is quite an impact, whether we're returning to school or whether we're going to have blended learning or whatever those models of learning are. We need to be kind of actively supporting young people. So that's obviously kind of talking to each other, creating those routines of that kind of day-to-day, just that 24-hour presentation. It's not just FASD in one context, like I was saying, it's home, school, and kind of the wider community as well. Making sure we're active, making sure we stay connected. I mean, obviously, Teams is great, but we know that a lot of people really need that kind of obvious face-to-face kind of connection as well. Making sure we take care of each other as well, and just being kind to ourselves, and that this is a time for compassion as well in the midst of everything. At the side, the left of this slide, I've highlighted some kind of key supports. Obviously, the FASD Hub have some great leaflets as well. I always kind of recommend lots of resources from the Young Minds kind of website as well. Just looking at those kind of secondary presentations around mental health, anxiety, depression, what does that look like? Obviously the internet is a great source of information, great wealth, but Sometimes we need to pick and choose the right resources at the right time. And if we're not sure, having conversations with professionals just to kind of figure out what's going on here as well. Now, this is kind of, before I hand on to Morag, she's going to kind of cover the next section. I also found this resource, and I think it's great. So this is me and my FSD, and as part of our young people's well-being, for those who have FASD, psychoeducation, actually understanding FASD for themselves, understanding their own narrative, their own story, is really important, because if it supports their self-esteem and their sense of belonging as well. Kind of understand that they're not alone. This is part of their identity too, and that they deserve support, and they kind of need to be supported at this time as well. Okay, I'm now going to hand on to Morag. I'm really conscious because Moira is such a strict chairperson today, so I'm hoping I'm on time.
No, you are, and thanks. Are you happy just to skip the slides on, as I say?
Yeah.
Hi everybody, so I'm just going to talk a wee bit about how we fit into it, and just without going over COVID and the trauma and bad stuff we've experienced in the last year, talk a bit about how schools and parents particularly are working together. So unfortunately, Alexa can't help us homeschooling the children yet. I saw this picture and I thought we can do a lot of stuff technology wise, but at the end of the day, for both home and school learning, part of our job, Miranda and I, would be to look at strategies that work and things that would help in the classroom, but also at home. The big thing for me is I've just put 6 points there, and these are some of the points that come up quite a lot. And this has happened as Miranda and I's role has changed a bit in the last year. We've not been out at schools as much. The good thing for me is that we've had time to talk to parents directly more. I would say I've had more phone calls with parents and been able to discuss things with them. So I would say this second time around with the school closures, parents and carers are a bit kinder to themselves and being a bit more self-care for them, I suppose, which is a big worry for me. But you can read through them yourself. I don't need to read them out to you, but the thing for me is that the link I've put to the brilliant NHS Ayrshire and Arran What Educators Need to Know document has lots of strategies in it. Teachers and staff in schools often ask Miranda and I questions about this, and very often we refer them on to this resource or other resources to kind of do more CPD and professional development on what it actually is and what they need to know. But the quote at the bottom for me actually came across when Paula and Gemma were speaking, because the best practice I ever see is when the parent or the carer is involved with the school in great detail. And otherwise, we can advise strategies, but if the parent is involved in that discussion, it just doesn't work. It's just school trying things or us trying things, and we're not working in partnership, which brings me on to the next slide, Miranda. So in Scotland, I know all of you will be familiar with Getting It Right for Every Child. We have many different resources freely available online on Edinburgh City Council's website. I've put one there that directs you to a flowchart, but if you just search for Edinburgh Council GIRFEC, there's lots of documentation you can have a look at if it would be useful in your roles, or even for parents just to see how schools should be doing things. The one bit I've picked out from it is just, can your pupils' needs be met within the school? If the answer is no, then straight away the school should be having a child planning meeting. And many of our children and young people with FASD should be at that stage, and we should be aware of them as educational psychologists quite a lot. So we would have a planning meeting, we would come along and we would see what else could be done in the school to support that. So I would say, just to, I know we don't have a lot of time, but just to say and reflect on what Paula particularly said, I've worked in Edinburgh for 9 years now, and 9 years ago I would still see parents having to bring videos of how their children behaved at home, and quite often would bring their phone out to show the school or the head teacher. So that doesn't happen anymore. I think we've moved on a lot, that the schools, with our help, sometimes have appreciated that actually parents are seeing this explosive behaviour at home. And quite coincidentally, I spoke to a mum this week on the phone, and her boy was the opposite. He actually explodes at school, and at home that's where he's quite calm. So this period for her has been blissful, which is good. That's a nice story to hear. But I think we've definitely...
5 minutes. You've got 5 minutes.
Oh, great. Thank you, Moira. Thank you. So the last point there, just when we are calling a child plan meeting in school, the big thing around it as well is for you guys as parents and carers to see that you've given consent and that it's been explained to you what it is. And personally, I think that is something we're not good enough at yet, and we need to get better at. So Miranda and I attend a dozen of these meetings a week, probably. Sometimes it feels like we have a dozen a day when we've not arranged our diaries very well. So we know what they are, but that we've just got used to them, but they're quite intimidating for parents to come to, and it takes a wee while to build up that relationship and understand how it does work. So we're always really willing to hear your feedback as professionals and parents on how the process has worked. And again, that links us on to the Equality Act 2010. Again, I was speaking to a parent about this just a few weeks ago. So particularly in Scotland, we presume mainstream for all children, and where possible, we try and support them in their local mainstream schools. And in some ways, primary schools are further ahead and kind of more universal supports that support a lot of children with different neurodevelopmental disorders. But certainly within the last few years, particularly with a lot of this work in Scotland that's been done, the secondary schools are becoming more aware and catching up a wee bit as well. But just be aware of the Equality Act, because actually sometimes our schools can adapt things within their own environment to meet the needs of children with FASD. So this may be for the individual child, but some things that I've seen recently is schools have spent a bit of money on having their own sensory room, or they've looked more at, I mean, Gemma mentioned it earlier again as a parent about the child being angry or scared. There's been a lot more timetabling of, I'd say, restful or relaxing activities in children's days, and sometimes that's for the whole class. So there's a lot more cosmic yoga for wee ones, or some after school clubs now are mindfulness after school clubs, not just active things. So there's a lot of great things going on that I've seen, and there's always improvements to be made. But I think for me it's very positive. And as Moira said in the introduction, Miranda and I have got this in the Psychological Services Improvement Plan. So every so often we meet and we review what's happening and we look at what we can do next to build this, certainly in Edinburgh at least.
Morag, did you just want to mention about, we've got lots of terms at the side in terms of interventions, adjustments, supports and strategies?
Yeah, so with regards to that, I mean, I've mentioned Equality Act as the legal side of it, but there's many different, I see Ailsa's mentioned, I'll come back to your point, Ailsa. There's many things we can do, and I think I mentioned we can do together. And it's good today, all the presentations we've had, the reason we've put those different terms is because different things can happen in a school or in a class. And today the message for me is that we all need to work as a team to make sure those things do happen. Ailsa, thank you for the nice comment, but I think you are right. I think that Ailsa particularly has helped us in Edinburgh see it from the parent-carer point of view. But I do think, again, referring back to Paula and Gemma, we need to learn more from what's happened in the past and not worked, and that's where we need to bring in supports and strategies for these children more universally, I would say. Miranda, do you want to come in with anything to add to that?
No, I was just going to say, I suppose a lot of those terms are interchangeable, but really they just mean the one thing. So when we talk the legal context, the legal language is adjustments, but actually it's all interchangeable in terms of intervention support strategies. That's what we're all talking about as well. I think that's us, Moira. Do you want to?
Thank you. Thank you. A number of questions on the chat. You're probably seeing them yourself. What are your experiences of how an FASD diagnosis can support understanding in education?
So for me, Miranda, do you mind if I come in? For me, it's, I mean, Miranda and I both are quite similar in that without the diagnosis, someone asked us of Jen earlier, I think every individual child, even if they have FASD, is completely different. And that's why the child planning process is really important. So, but the big thing for me is it's really important for the parent and carer, and it's also really important for the child. And I know Jen's team initially, when your team started, you did a lot of work with children on this. And Ailsa mentioned there, she can't compliment herself on the chat, but just to give her a compliment, Ailsa's worked with one of my girls who's in S2 at high school, has a diagnosis, and she's been doing a bit of work with her on what that means and how her brain works. And that's been invaluable for her to stay in her mainstream high school and do well. So that's a really, really positive piece of work. So I think the diagnosis is important.
Yeah. I was going to say as well, I suppose, you know, the significance, the value and the impact of an FASD diagnosis is that, you know, in terms of not only the individual, the family, the school system, because we're not just talking about the classroom, but the whole school, that they understand, you know, this is the individual, like every other child, this is how they present, this is the underlying reason for what's going on, and a bit of kind of recognition and support around that. But I think when we are in a planning process, the ability to access other systems, because that diagnosis is in place, is key, because obviously the GARFEC planning meetings are located in the school context, and professionals tend to be drawn in, you know, kind of when need arises. So when we have that clarity around a child's profile and what's going on, it helps to then kind of specify, you know, what do we need to do next for the child, and then kind of look at the appropriate resources as well.
Miranda, what's the average age of referrals? Do you have that?
Sorry, for
average age of referrals to psychologists in the educational system.
So generally, what we actually, so Morag and I work across kind of an age span generally of about 3 to 18. Obviously, when children within Edinburgh, we have special school system as well. So children's needs as they arise, so it won't be determined kind of early on. It'll just be that actually the child is needing support, and it can't be supported necessarily in the classroom. The school then looks kind of externally to us. So I don't think I could say definitely, but you know, you do tend to see in primary school, once they've settled into primary 1, that can be a key point of transition. Yeah. Obviously, in terms of diagnosis, we know it's a little bit late, it's going to be after 6, but you start to gather that information, which is really helpful about what's going on for the child. Are they struggling in terms of their learning? How is their kind of behaviour? How is their social interaction? You gather a lot of key information, that kind of contextual information. So actually, as time goes on and as interventions go on, you're then able to kind of suggest to school and parents within the context of the GARFEC meeting where we need to go next. Do we need to have health involved if they've not kind of already been involved?
And just as one last aside, Moira, I know you're keeping perfectly to time. We've got 1 minute.
No, you can.
Just some positive news for the future. There is a training programme for teachers, and if they have a diagnosed kid in their class, then they will come along to that. We're looking at more universal training, how that would work, and if that's something we could link into with across Scotland, that would be great. And I see Kirsten's mentioned, put up a comment there as well. Kirsten and Miranda and I have recently been talking about neurodiversity, neurodivergence training as well. So kind of tying that all in with teachers, because teachers and staff in schools are really interested in this. It just depends sometimes what the council's priorities for training are. So there's lots of questions and lots of enthusiasm out there.
Yeah.
Started by Jen and her team.
Yeah.
Thanks, Morag. And again, really good example of the importance of us having some idea of the numbers of children who are involved, so that when people go to councils, they can say, these are the proportion of children that are involved in this. Yep. And it can actually give you some clout in terms of that. A lot of comments coming through on how helpful it is when an educational psychologists are FASD aware. So it's working. Well done.
Right.
And I think for me, starting where the client is, you start where the kid is. And those practical things are so important for parents. And I want to join a cosmic yoga class.
Yeah,
I like the sound of that. That sounds fabulous.
And the mindfulness after school club.
Yeah.
Absolutely.
Oh, amazing.
Thank you both. That was really interesting. Our next presentation is by Stephen McLeod. Stephen is Professional Advisor in the Mental Health Division of the Mental Health and Social Care Directorate at the Scottish Government. Stephen's presentation is on developing a national neurodevelopmental service specification for children and young people. Stephen.
Thank you, Moira. Hopefully that camera has turned on, has it?
Not yet. Oh, there you are. Hello.
That's good, thank you. So first of all, apologies in advance. The postman hasn't been yet. I've got a very noisy Cocker Spaniel, so you just have to bear with me, and welcome to my world for the last 12 months. And I'm about to share slides. So I've deliberately taken less time than has been allocated, Moira, because it would be good to get some feedback from colleagues and have time for discussion.
Okay.
What I'm going to try and do in the next, hopefully 15 minutes or so, is to give you an idea of what we've been doing for the last 3 years. So there's 3 years of work here, and many of the names that I can see in the chat are familiar to me, colleagues that have worked with me over the last 3 iterations of what was the task force. So this is a strategic presentation, essentially. It's the development of this policy within government and a summary of why we're doing this, what we've done, where we are now, and the next steps. I think it's particularly relevant for this discussion that you're having because, well, for 2 reasons. One, the children and young people who experience FASD right on cue, were in scope right from the very beginning. So the presenting issues that those children would come with in early years and that school-age children were within our scope. And the second is that our scope is quite wide, and I can explain that in that it's trying to fill a gap that we think exists, that was identified at the beginnings of the work of the task force, the Children and Young People's Mental Health Task Force. So enough about that's what I'm intending to do. Happy to take questions. If there's any follow-up, Moira, I'm happy to take direct emails from colleagues or messages in Teams, and I can follow up after the meeting. Because I'm actually having this, I'm doing this again later for the Children and Families Leadership Group in Government. So it's a day of neurodevelopmental presentations. So let's see if I can share this. Can colleagues see this?
Not yet.
Seeing the slides, Stephen, on the note format, not the full screen slideshow yet.
So there we are. Can you see that now?
That's perfect.
Okay.
I'm sorry, I'm not seeing it, so others may know. Oh, there you go. There you go.
Thank you. So just language and definitions are important, and I found that out to my cost right at the beginning of this discussion, probably in the summer of 2018. We took a deliberately inclusive approach in the Children and Young People's Task Force. That was the Children and Young People's Mental Health and Wellbeing Task Force. Many of the people in the meeting today were involved in that to a greater or lesser extent. So that's the first point to make, and the second is just to give a quick tour of that work. You may remember Dame Denise Koya, who chaired the task force and very sadly passed away in April 2019. I knew Dame Denise for many years, worked closely with her, and she was a great loss to us. because the task force did great work in the first 12 months, but had to then migrate into a different set of arrangements, namely the Children and Young People's Mental Health and Wellbeing Programme Board. So the reason that the task force is important is because the government commissioned a review of what is called rejected referrals for CAMHS. So the numbers of young people referred to CAMHS who were not seen or treated there. And Dame Denise did some work with the Children and Young People's Mental Health Youth Commission and others. And we realised that many of the children and young people referred to CAMHS probably met the criteria for neurodevelopmental profile and support requirements, but did not meet the CAMHS criteria. And because there was no national service specification for those children and young people, there's no waiting times guarantee, for example. We don't have workforce information for the sorts of professionals that would be involved in that activity. And we didn't know very much actually about the demand and the experience of children and young people at an aggregate level in Scotland. This was one of the task and finish groups created by the task force. So we did work in the task force up until July 2019, and then in August the programme board was formed. That created a task and finish group to complete the work, and I led both of those groups. There's a large group of professional bodies and representation from across civil society in Scotland, lots of the right professional groups. The Children and Young People's Programme Board also had the benefit of direct input from families and from children and young people themselves, who were organised via a network of voluntary sector agencies and a participation officer that actually worked directly with the programme board. So if colleagues are aware of the CAMHS service specification, you realise that they're very deliberately written from the perspective of children, young people and families, and that was the aim for the neurodevelopmental service specification too. Some of the people in the task and finish group, and this is the programme board's task and finish group. I can see other colleagues were involved prior to that in the task force. So it's been quite a period of intense engagement. Task and finish groups met 6 weekly or so, and lots of digital and electronic work in between times. And obviously that came to an abrupt halt actually. The last meeting of the task and finish group was, I think it was in mid-March. It was 18th of March or thereabouts in 2020, and it was just before lockdown. So we'd completed a lot of work but hadn't quite finished at that stage, and then we had to set that aside and respond to the needs of services in the pandemic. And I ended up doing something different entirely for 6 months because that's just what had to happen in government. So a timeline there, and just a reminder of the process. Lots of engagement, lots of people involved, quite a broad range and focus on needs of children and young people. Not taking a diagnostic approach at this stage, but looking at the presenting issues that children and young people, particularly under the age of 8, would present with that could indicate that they had one of a range of neurodevelopmental profiles of need and were indicative of further difficulties later, and also would respond to early intervention and support. Lots of feedback on what we are now calling the draft service specification. This is prior to December last year, December 2020, when I presented the first draft of that to the last meeting of the Children and Young People's Programme Board. Most of the feedback has been positive, that this should exist. There should be a set of standards, that it should be written from the perspective of children, young people and their families, i.e. what support they should receive. Lots of concerns, I have to say, about resources, particularly colleagues within local authority settings. I've done a lot of work with ASPEP, Educational Psychology Group, and they are particularly concerned about the impact. They're very keen to be involved, but they want more reassurances, I think, that they would be supported locally at a local authority level to have the resources to engage in what is quite a change in the arrangements from what exists just now. So what I wanted to do just now is give a run through on what we agreed to deliver, and what I'm pretty confident that the final service specification has these components, and this, Moira, would be good to get feedback, particularly in the next 2 slides. So it's really important that it was based on getting it right for every child practice models, just for obvious reasons. And that means that we're not creating another standalone or separate pathway for children. Ideally, all of the additional supports, requests for assistance, as the young person might call them, should be based on a good understanding of the child via the child's plan. Now, that is an experience that's probably patchy, but for this particular discussion, it's really important that neurodiversity, people are aware of that, and capacity for training and awareness, and also the resources, particularly at a preschool and a school level, are available. So we maximise the potential to identify these needs at an earliest stage possible and respond to them. So we heard from many of our academic colleagues, and particularly in the early stages of the task force, to say that probably half of these children are known, and I mean the whole spectrum of neurodevelopmental profiles of need, probably before the age of 8. I think some of our professional colleagues and academics said you could be more optimistic than that. So the early years was critical. The 30-month review was a critical period, a great opportunity for a universal assessment of a child's profile and identification of children, for example, who had concerns about their developmental profile or communication difficulties. Communication needs came up time and time again, to be honest. It seemed to be such a good indicator of a requirement to get involved in a child and family's life and to provide support early on. It has to cover the life course. So, for example, the transition to adult services that some colleagues may be aware of is described in the Transitions Care Protocol or Pathway. And that was an instruction from the Mental Health Minister to make sure that young people leaving CAMS had a good transition into adult services if they needed it. The principles of that document apply here too, and so it's important that they are included in the service specification. I've already mentioned this in terms of supporting the existing system. So, basically upskilling and increasing capacity of people who will have day-to-day contact with children and young people and their families, making them more aware of these needs and better equipped to respond to them. And then the children's services system. So, I'd include, for example, children who are looked after and accommodated. There's good evidence to show that there's an increasing prevalence in that particular group of children of these profiles of needs. Working with all children's services, including the voluntary sector agency. So this is the particular area that I'm, as a former head of service, general manager within the NHS that's managed children's services, this is the bit that I think I probably worry about the most. Assuming we did all the items in the preceding slide, do we have access to this reliably in all parts of Scotland? And even on my work on CAMS, the improvement for CAMS, I know that this is unlikely. There's further work to be done in terms of the pathways and resources and services that are available to children and young people, but I think it's fair to say that it's patchy, and also the absence of a national agreed definition and standard doesn't help. And then the training, the staff that work in this pathway. So you haven't seen the service specification, but you hopefully will see it when it's published in the spring. We've been very careful to specify the types of professionals that we think should be involved, and it includes, for example, educational psychologists. It includes a number of AHPs, children's nurses, paediatricians, child and adolescent psychiatrists, etc., etc. The groups of these staff have to be available. They have to have capacity. They have to have the time to be able to respond to the needs of children who perhaps don't meet the CAMS service specification criteria or other thresholds. Because the point I made earlier, that early intervention is critical. We're not looking for blue lights and urgency in this profile of need, but the indications that you can identify very early on are good indicators that the child is going to need support later on. And then, sorry, the last one is about access. It's a quality measure that the government have focused on over the years for health and social care services. It's not the only thing, but I don't think you can have quality without access. But you have to do other things to achieve quality once you've got access. So the stories from families on the CAMS redesign programme and the task force were quite heartbreaking, actually, about waiting a very, very long time and not sure they were waiting for the right thing and in the right place, and then being unsatisfied with the response that they would get. Some of the longest waits in CAMS have grown during the pandemic, and I'm pretty sure that there are children and young people on those lists that would benefit from this sort of service and are probably waiting for something that CAMS doesn't actually need to do. So just a quick update on where we are now. We aim to publish in spring 2021. The programme board has been replaced with another group, which is a partnership between the Scottish Government and COSLA. So I like to joke that this is the third task force that I've worked within, and if I keep going in government, I might work in a few more. But it's really important that that partnership exists, because the government can't do this on its own. It needs partnership with local authorities and localities. I think the list here are the recommendations that I made to the programme board that were accepted. So we need to support implementation of a standard that's agreed. We need to get a clear understanding of the baseline of current arrangements, so the resources that we currently have deployed and the pathways, and of course the gaps, and then the new requirements. And the £120 million that was announced recently by Ms Forbes for mental health services is a great opportunity in 21-22 to do something about this. And I've certainly recommended to civil servants that this work is a priority for the resources that it may require. I'm pretty sure it will require. So the last one, not least of all, is the data that we have is quite poor. So if we want to understand the experiences of children, young people and families with this profile of needs, we have to gather more information in a routine and a structured way, and we have to make it available locally and nationally. So that is another area that we've recommended. There needs to be an investment in the digital infrastructure to gather that information and to be able to report on it. So thank you, and happy to take questions now or hear comments from colleagues, or questions later if we don't have time. Thanks, Moira.
Thank you, Stephen. That was helpful. We've just a couple of questions coming in. Can you tell us about how FASD is referred to in the service specification and how this will help families who may be listening?
So, as I said earlier, we looked at, with guidance from the academic advisory group and particular people with an interest in this profiles of needs. So, for example, Professor Helen Minnis, that many of you will know, and others have given us advice on this. We looked particularly in the early years at the common presenting issues. So trying to think about this in terms of how children, families, young people present. And I know from working with Jen Shields, for example, and other colleagues, that there's a big overlap between some of these presenting issues and children that would be identified as having experienced FASD. So that is it. We deliberately didn't list a list of diagnostic outcomes, knowing that many children in Scotland right now don't have access to achieving a diagnosis or knowing what the profile of needs of their child is in a formal structured way, but rather turning that around to say, for example, I mentioned communication difficulties. The Sure Start language measure and things like that at 30 months are very useful indicators of communication difficulties at that stage. That could indicate other things. So secondly, Moira, FASD would be included in a potential outcome of the structured professional assessment that we've recommended that is available to every child. Now, other diagnostic outcomes may be required too, or will have to be available. But so the question for us is that core team that has the skills, knowledge and experience to be able to identify children with a range of presenting issues and who may acquire a range of diagnostic outcomes.
Yeah. Thank you, Stephen. There are a number of questions and comments on the chat that I think you might find useful. And I suppose the bottom line with everything of this is the money, is how the money is apportioned. And I'm repeating myself at the risk of being boring, Freud, that we need to know what our numbers are, and so that we can look at service provision. And I think that the Scottish Government has really done a very good job over the years in FASD compared to some other things. It's desperately needed, but I think we really should be very pleased. There'll always be a sense of there's not enough money and when are we getting more, but I think in a supportive way we have to acknowledge the amount of work and effort that's been put in. So thank you very much, Stephen. That was really helpful. Okay, we're on the last lap, guys. You remember the first session in conversation earlier today. This is the second session. It's Barbara Aungston who's talking with Carol Hunter. And this section is on the voice of the individual in conversation with adults with FASD.
Thanks, Moira. So we've heard a lot this morning about clinicians and professionals' experiences of FASD. But to bring our conversation today to an end, I think it's really important that we bring it back to the experiences of the individual with FASD, because it's the individual with FASD that's at the heart and centre of all the work that we do. So I'd like to welcome Carol along today, and I'm not going to say very much to introduce her because Carol is very capable of doing that herself. And we're going to have a bit of a chat, and you can listen in as we talk a little bit about the experiences that Carol has had throughout her life. So welcome, Carol.
Hi, thanks for having me.
We're very glad that you're here today. So maybe you can start off just by introducing yourself and telling us a little bit about your early life.
Yeah. So hi everybody, my name's Carol. I was diagnosed with fetal alcohol syndrome when I was born due to the facial features that obviously presented. I was then put into care and I was adopted at a young age to a very loving family who were made very well aware of the implications before adopting me and the challenges that they could face with me having been diagnosed. They were pretty much told not to expect much, that I wouldn't achieve much academically and I'd struggle socially. But they wholeheartedly took me on board anyway and thought, we're not going to listen to anybody and we're going to prove them wrong. So they didn't really open up to any support. There was a lot of stigma around it. My mum didn't really want any more labels put on top of me and felt that, we would start afresh. She gave up work to look after me and make everything as educational as possible to try and help me, with before starting school and things like that. So yeah.
That's great, thanks, Carol. So what was school like for you? What was your school experience?
So I struggled at school. I had a temper. I didn't know how to read certain situations and stuff, so I did get into a lot of bother, as many children do. No fear or noticing anything around me. Academically, I struggled. Primary school wasn't so bad because you were still at a young age and it just thought you were maybe acting out because you'd been in care, and that's the kind of label that it was this, oh, her past's been bad, that's why she's acting out. High school really struggled, fitting in. My mum and my adoptive mum and dad really wrapped me in cotton wool. So as much as like socialising with friends, like, down the park or stuff like that, or sleepovers and that, I wasn't allowed to do any of that. I realised why they did it. They tried to be protective, but I think I lost a lot of the social elements that normal kids experience, unless they're normal, but you know what I mean. And they did socialise me with, like, piano lessons and dance classes and stuff like that. So there was that social integration side of things, but I think a lot of it, streetwise, was kind of lost a little bit. I struggled through high school. I used to have to, everybody was out, enjoying themselves. I'm in a room trying to just take information into, because it's been drilled into me that I need to get my qualifications if I wanted to get anywhere. It was so important. And that was the main focus through high school with my mum and dad with me. And I get why they did it, but at the time, obviously, I did rebel a few times regarding that. But I got through high school. I stayed on and I got hires somehow. Managed to do it, but I did get qualifications that they thought was not possible. So yeah.
Yeah, you did get some qualifications, and after school you went on to university. Maybe tell us a little bit about that experience.
So I didn't think I would get into university, but I'd apply anyway. You know, my mum would help me with like application forms and stuff. And I noticed that she didn't tick or allow me to tick that I was care experienced on any of the, you know, the enrolment forms or anything like that. But I went to university, so I grew up in a small village in Fife and then went off to Aberdeen. So as you can imagine, with no life skills, I was like a rabbit in the headlights up there on my own, finding it hard to, you know, used to be quite reserved and find it difficult to make relationships or speak to people. And it was horrendous for me. I thought that, you know, I'm not capable of this. There's no way I can do it. Really, really struggled. And I dropped out after a year. Went home, you know, tail between my legs, saying, I'm so sorry that I've disappointed you. I'm just not capable. Loads of student debt, nothing to show for it. So yeah, and things weren't great at that point. Even, you know, at that age, I was still struggling with dealing with that and would lash out and things. And relationships with my mum and dad broke down at that point as well. But, you know, we pulled it back. It's different now.
Yeah, so I think what you were saying there was a reflection of what we call a spiky profile in individuals with FASD. So you were achieving academically, but your life skills and other areas of your development were maybe not quite there at that point in your life as well. But later on in life, you have a partner and you have children as well, but you also returned to university as an adult, didn't you? Do you want to tell us how different that experience was?
Yeah, so I went back to college when I was 34. I give my age away now. So I went back. My adoptive dad had cancer in 2014, so he urged me to go back. He's like, look, you're more than capable of doing what you're doing. We all believe in you. You've got, you know, the life experiences behind you. You kind of got a turning point in life, and you realised why things happened, where you were now, and you know, it just like it all clicks into place, and you see, you know, what you want to do. So I went back, did a HNC. I had 2 kids at the time. That relationship broke down, so obviously that was challenging as well. Being a single parent back as a mature student with a bunch of 18, 19-year-olds, and you're just like, why am I here? But persevered. Went on to do a HND. Had my 3rd son during that HND as well. Took 5 weeks off, but managed to get through the course. And at that point, I was done when I had my HND. I'd got involved with the Student Association, was student president, which was totally out of my comfort zone, but somehow found my way into that, and it was leading into lots of opportunities. And then my tutor advised me to have a look at Open University to do my degree, because obviously I was a mum of 3 kids, so it was really difficult for me to up and go to university. It didn't work in the past, so why would it work again? But I thought I would give it a go. Obviously, college was a total turning point for me. I grew up not being able to speak about my past, or, you know, what, you know, my mum was like labels shouldn't define who you are, so we don't talk about it. It was like, it was a closed book. We were a closed family, and there was the whole pride thing and everything that went along with it. She didn't want people knowing. But when I went to college and, you know, working with the Student Association and opportunities with the Open University that came out of that, they got me to open up and speak about stuff, and it led to so much additional support being put into place at our college for, you know, care experienced students, and to see like how you just think you're just normal and this is just the way life's been, and how you sharing information can really, you know, help other people understand who they are, and the implications of that. It's grew arms and legs. So obviously I did my degree, I got a 1st class honours degree. I'm now in my 2nd year in my Masters in Crime and Justice, and I'm now a guidance advisor at the college. So yeah, I found my way eventually.
Oh, you certainly did. And I know you remember the children's panel as well, and you've got lots of things going on and offering your experiences that you've had over your life. You're very much using those experiences now to support other people, which is just, it's great to see. Could you maybe share with us some of the strategies that you've used over the years to overcome some of the challenges that you've faced?
Yep. So one of the things that's come to light that I'm really good at is being overly busy. So as you know, I'm involved with loads of stuff, which is great for me, but I'm one of the people that needs to be on the go all the time and have, you know, my mind constantly focused on something, or, you know, feeling that I've got involvement on something. So for example, when I finished my degree, I wasn't going to go on and do further study, but I felt lost. There was something missing. And when I'm not busy, my mind goes into overdrive. I'm an absolute nightmare. And some of the stuff that I was like when I was younger, you see that coming through again, and you're like, nope, I need to go back to being busy. You know, and I think that's all part of it as well. Like I'm 24/7 all the time, unless it's bedtime. But that's how I cope with it. Obviously learning and stuff. I have loads of books behind me that's like, the contents are the exact same, because it's repetition, writing it down. It's the only way I take it in, you know what I mean? And that's why I'm involved with a lot of the widening participation stuff with, you know, the college and things like that, because it's all about inclusive learning. You know what I mean? You don't change, and I've said this to you before about, you know, a flower, if it's not blooming in an environment, you don't change the flower, you change the environment. So it's like sharing these experiences and getting other students to own their identities, where they've been, and share with other people to try and change the misconceptions. You know, a lot of stuff's always focused on the negative, saying this is what's wrong with them, this is the challenges they're going to have, so kind of that's it. And it's like, well, no, we need to celebrate the small milestones. We need to celebrate the small successes, as little as they are, they're successes. And we need to, you know, and it's that positive, you know, reinforcement and things like that really changes people's perceptions. You know, a lot of people, when I speak about myself, they're like, oh, I would never have thought any of that from you. And it's like, well, you know, we're all capable with the right support. It's just making sure that that's in the same for FASD as it is with every other, you know, condition that's out there.
Yeah, absolutely. So you've spoken there about some of the things you would like to see. Is there anything in particular that you would really like to see changed in regard to FASD in Scotland?
I think the work that's been getting done is great. Obviously, in an ideal world, you know, early intervention is key. You know, so that the right support and everything can be in place. That then, you know, it impacts the schools and it'll impact colleges, because they're all fully informed. I mean, there's a height of ignorance about it, but it's not really. It's miseducation about it. You know, and I think the more education that we do about it, you know, the implications, how to change things, you know, how to change the environment and learning and everything, really, really will benefit. And we know, you know, the early intervention and different strategies and stuff really do make a difference to someone. In an ideal world, if it could be, you know, that this was diagnosed, or it was part of, you know, the development of children, you know, when they're younger, when you know, in their little red book and stuff like that, that would be amazing. But again, that's a long, probably way away, but I think we're slowly chipping away, you know, bit by bit. That's all we can do.
Yeah, I think early intervention, right, is really, really important. I don't know if I told you that my son was diagnosed at 4 months old as well, and early intervention has made a massive difference to his life and his outcomes so far. So this is your opportunity. You've got all these professionals watching you today. Is there a key message that you would like to share with them today? They're going away. This is the last comment to be made. What should they know? What should they remember from today?
I think it's just to remember to keep doing what you're doing. You're all fighting a good cause and wanting to change things. And I think collaboratively that we can do that. It's listening to the experiences of people, you know, having them at the heart of the conversations is key. You know, getting those mandatory training sessions in schools, colleges, you know, health professionals everywhere. You know, if we could have yous at every single training event, that would be amazing. You know, it's this whole misconception that people are like, well, for me, the FAS at the time, because it was in the 80s, wasn't really looked at. They just thought, right, well, she's been cared. That's the root of the problems. And it's trying to, but it's not so much that they don't want to deal with it. It's because they maybe aren't fully aware on how to, and it's how we address that. And just that itself would have a knock-on effect, you know, with stuff going forward. So yeah, I think
that's great. No, thank you, Carol. Thank you so much for coming along to speak to us today. I really think that I'm sure that the chat box is very busy, and yeah, and people have really appreciated what you've got to say today, because you are the expert in the room today, the person with a lived experience. So thank you so much for joining us today.
No problem. Thank you.
Thank you.
Thank you, Carol. Thank you, Barbara. Carol, just a lot of very positive comments. Huge thanks. I think it's really important to remember that it may well be that some of the people who are listening in today and watching actually are people with FASD. And seeing you standing there so articulate, so honest, and I really appreciate your honesty. And just giving, you know, wonderful examples of how things can change as life changes. Opportunities which don't work out at one point may well work out at another. I think that celebrating every success is something that's just so important. So thank you very much. I just have a few comments to wrap up today. This has been the first National FASD collaborative event. I hope you found the day useful. There have been a number of themes coming up, and Jen's very kindly put together 4 of them, 3-4 of them for me. The voice of the individual with FASD and caregivers to be included at all points. And that's come through a number of presentations today, and we've also clearly seen how important that is. The need for people to be FASD aware and to have early identification is crucial. Support as practitioners to make their respective services to be responses to those affected. I worked in the alcohol field for a long time, and it was very easy for people to forget how difficult it was for somebody to actually step through the door of the clinic and expose themselves in a way that was very frightening, and for many of them felt really very dangerous. This is similar. Lots has happened in Scotland in 10 years. Momentum is growing and strong collaborations have been made. You've seen that today, and there's lots to be hopeful about. We're very keen that we receive information and feedback from you, and we will have a feedback form to you. I'm not sure how we're going to do this, but perhaps early next week you will receive an email with a survey link to provide a feedback. I know you're asked to do that in every symposium, but I promise you we do pay attention to it, and it will help us when we're making other symposia in the future. I want to thank all the presenters, and at least as importantly, those behind the scenes who've kept the gremlins at bay most of the day. And I've just had another WhatsApp from Jen. Maybe reiterate new e-learning module and new website coming from FAST team soon. Also see FASD Hub for resources. Thank you, Jen. At this point, I would usually say safe travels home. I suppose what I really need to just say is stay safe at home. Take care, folks. And thank you again for everyone being present and giving us such really interesting discussion and debate and questions on the chat line. Thank you.